could I request all the colleagues sitting towards the back to come to the front? There are lots of chairs available and you could just come in, and whosoever is coming later can just enter through there and there'll be minimal disruption. So if you can just all move forward, that will be great. Good morning, colleagues. My name is Jyoti Ravichandran. I am the specialist for mental health and psychosocial support at UNICEF in India. We have a really action-packed day today in terms of only 2 panel discussions, but then a large portion of the focus is going to be on coming up with action plans based on the really rich discussions that we had yesterday. And we have a couple more panels going forward that will add to really important information and considerations for our deliberations. For the first one, we have case studies from states and the roadmap ahead. I really want to give my good mornings also to colleagues from the Ministry of Health and Family Welfare and Home Affairs, and our moderator Shri Safi Ehsan Rizvi, advisor to the NDMA, is already here. If I may please request the panelists to join us here. We have Ms. Zoya Arun, who's the hazard analyst from Kerala SDMA. We have Dr. S. Manoharan, who's a social science expert from Tamil Nadu SDMA. We've got Dr. Abhishek Pandey, CMO 16BM NDRF. And we have Mr. Gauri Shankar Mishra, who's joining us from the Odisha SDMA. Thank you, and take it away, gentlemen.
Morning. Hi.
Also, colleagues, one more reminder to please join us in the front. Thank you.
Well, when you've been a backbencher since KG, then you can't help it, no? You have to sit at the back. So it's okay, but please do participate. And if you can, it's okay. I mean, if nobody wants to shift, it's fine. We've again kind of started a few minutes late. Last morning we were about 15 minutes late, then we were overtime all through the day. So today we'll try and speed up the deliberations. So we are going to, nobody has a presentation, no? You have? How small is it?
8 slides.
Huh?
8 slides.
8 slides, well, okay, we'll accept that it's small.
10 slides.
Oh, okay.
I will try to make it small. It's a big presentation, but I will try to present it precise.
I am so petrified now. So can we give you a laptop so that you can choose those slides right now, and then we can put it on?
Yes. Yeah, he has, and I already spoke to him.
If you want, you can like go to him and edit it and bring out the presentation the way you want, or you'll just...
Yeah, I will manage.
Okay, good. So we'll quickly go through those. The point is that we have 1 hour and we have to do that quickly. So please, the speakers, I'll request you to do your thing in 5-7 minutes. We want to focus on your case study. Please do not start from the beginning because we've discussed the beginning yesterday. So if we can get the, jisko Hindi mein kehte hain, saransh of your understanding of what that case study showed and the nuances, that would be of great interest to everybody. Second kind of housekeeping announcement is that all the presentations that were showed here will be shared on this thing, whatever it's called, QR code. This thing will have the presentations and it will have the photographs also. And I would request the camera person to take photographs of the participants. आप ले रहे हैं photographs participants की? या हम ही लोगों की खींचे जा रहे हैं? भाई participants की अच्छी photo खींचिए जिसमें high resolution photo हो, in which they can put it on their LinkedIn post and Instagram. Then the program will also be there, the schedule and everything. We are not putting everybody's phone numbers and emails. That you can, if you want, you can always talk to each other and exchange them. Otherwise, you can ask Dr. Ghanishta. She will give it to you whenever you wish to have one. So that's a bit of a housekeeping announcement. We'll try and stick to time this time. And let us start. So we will start with Tamil Nadu, I think, Dr. Manoharan. But sir, I'm going to be really strict on time.
Please.
I'll be like a professor.
Please.
Okay, sir?
Okay.
Who feels that the exam is, you know, if the guy gets to write even 1 second extra, he'll have to check a little more. So Dr. Manoharan, just one word about yourself and then the presentation.
Good morning all, and thank you very much for this opportunity. I am Dr. Manoharan, working for Tamil Nadu State Disaster Management Authority as social science expert, and I am also looking after psychosocial well-being, right? So I'll be thank you. So I'll be briefly presenting the journey of psychosocial support in Tamil Nadu, right? See, the state is committed. The state is committed through a state disaster management plan. The mental health care of disaster-affected pregnant women and lactating mothers, neonatal, aged, and terminally ill, and those suffering from chronic diseases receive utmost priority as they suffer from double jeopardy. This is very clearly stated in our state disaster management plan. And mental health and psychosocial support communities perspective, and yesterday also someone was raising a concern. What would happen to the cultural practices, right? So we recognize the traditional practices that take care of psychosocial support. It is inbuilt in our community, and especially in southern states. Tamil Nadu there is one practice called Opari, right? It's a grief, it deals with grief, right? So we give importance for that, and especially during tsunami, it was quite evident in 2004, the community, there were so many community kitchens spontaneously, right? Spontaneously. Nobody asked them to do it, okay? So the community responded spontaneously with so many community kitchens, and families supporting families, people supporting people, right? And Vapari was, really helped people a lot. Okay, Vapari is a folk song, right? And mental health during a tsunami, and state also had interventions, and there were so many players in Tamil Nadu during tsunami. There was WHO, there was NIMANS, there was UNICEF, there was UNDP, and many academic institutions played a significant role in delivering the psychosocial support, right? So NGOs were there, volunteers were there, and psychosocial support was it played a very key role during tsunami. There were so many children became orphaned, and we had to put them in institutional care, right? And interventions, we had trauma care sessions, we had group therapeutic interventions, we had community counseling sessions, recreational therapy for children played a significant role, and institutional care was there, rehabilitation, reconstruction, housing and livelihood. It was very quickly done, because many people lost their houses, and housing was it was something very close to the heart. So housing was immediately taken care of, and within 6-7 months we had housings for and very important thing, after tsunami, even after 20 years of tsunami, we are keeping in touch with the affected people. This is very, very important. And Dr. Radhakrishna IAS officer, who was collector for one affected district, who helped many children, and he still keeps in touch, he is still in touch with many affected people. Recently, he was invited by one tsunami affected child for her marriage after 20 years. He actually headed this. And we also still keep in touch with, the left side, her name is Usha. She is now a leader. She is a very good counselor now. Okay. So she was a child in 2004. Okay. So we are still keeping in touch with them. And mental health and psychosocial support during COVID-19. In fact, SAOC, Greater Chennai Corporation played a significant role, and NDMA played a significant role, especially the Department of Social Work of Miraj Krishna College, Layla College, right? And many more colleges played a significant role. They sent their volunteers to Greater Chennai Corporation. We had a 24/7 telecounseling service, right, during during COVID-19. And we also collaborated with the NGOs, And very importantly, we delivered telecounseling services to interstate migrant workers, pregnant women, children, families, and COVID-affected families. We had a network of, we created a network, or we had a peer group sessions also, COVID-affected persons speaking to recovered persons speaking to the COVID-affected persons who were in hospitals, right? And we had a one-to-one interaction, and we facilitated many COVID patients to write stories when they were in hospitals, right? And one aged person came out with a beautiful poem that was published, right? So this is the kind of, and we had a separate helpline for differently abled persons, right? Sorry, is it not working? And this is one, very, and actually UNICEF played a big role in this. Actually, this online kids workshop during COVID-19 evolved with the process. There was a demand, huge demand from the parents. We were having a discussions with parents. We were having this demand came from the parents. Please do something for the children, right? Because they are wasting time with mobile phones and this. And please do something. And this idea evolved with the parents' demand. We had an online kids workshop through which there was also yesterday there was a session on art, the role of art. So we had this online kids workshop for children. Nearly about 2,000 children participated online, and there were also some autism children participated. And we also have the feedback from parents. And this online kids workshop, we had this portrait drawing. We also had vocal music, okay? And this went on for 6 months. Right? 6 months we had a continuous engagement. We continuously engaging children. We are engaging children with some NGOs also played very huge role. And after 6 months, it was owned by the parents. And parents took over the whole program, and they were running the program. So next 6 months, the parents actually ran this program. And barefoot counselors, we had on pilot basis, we had with the support from NIMANS, we had 35 community-based volunteers trained by NIMANS, right, on psychosocial first aid, and they are still doing, service. And they have been serving as first responders, and even last Fenzal cyclone also they did a good service. And proactive measures preventing mental stress. Tamil Nadu has this program. Now it's a policy now. The pregnant women who are due to delivery within the next 30 days are shifted to maternity and child care hospitals in advance as a precautionary proactive measures. And this has been happening since 2002 and 2003 also. 2003, I think nearly about 800 pregnant women were shifted. Okay. And shelter and psychosocial support, we ensure that pregnant women and lactating mothers have a privacy, right? They have privacy. They are allotted separate rooms, okay? And this is ensured. In Almo, we have 121 multi-purpose evacuation shelters. See, this communication has gone to all the shelters. Prior to Northeast monsoon, this communication will go, and it is ensured. And Fenzal cyclone, we have a Tamil Nadu alert app through which we interact with people, and we also receive distress calls, right? And we attend them, and we do referral services, and many volunteers support us in this, right? And way forward, we are planning to institutionalize GO academic institutions coordination for enhancing MHPSS services. And psychosocial first aid, we have included one module. We are going to train 6,000 community-based volunteers. They are attached with 121 multi-purpose evacuation shelters. Each MPS will have 50 volunteers, right? We are going to train them on five modules, and one module will be the psychosocial first aid, right? And we also did a TNA. And TNA, the priority was given. It is coming from the people. Okay, psychosocial support is very much needed. Okay, so there is a demand from people, and in fact, people who got affected during tsunami, they know the importance of psychosocial support, right? And psychosocial support, we are also preparing SOP, and we are also, I think this draft DIDRR, Disability Inclusive Disaster Risk Reduction, is almost ready. One Balavihar Pioneer Institute in dealing with differently able persons, they are supporting us. They are the technical experts, and these the immediate things that we are doing. And thank you very much.
Thank you, Doctor. So that was just 2 minutes over time, so it's okay. Dr. Mishra, we'll have you next. 1 minute, half minute about yourself, and unless there's a lot to say.
It's okay?
Yes, thank you. You gave us good case studies.
Respected Safi Hassan Rizvi sir, Advisor NDMA, esteemed panel members, dignitaries and participants present in the hall. Myself, Gauri Shankar Mishra, I am working as a State Project Officer with OSDMA. So, my presentation is basically from last year we have started a project on psychosocial care for coastal communities, disaster affected communities. So this is not the first time that we are working on a project. Previously we have interventions, small scale projects, particularly with the help of UNDP and programs with the support of NIDM. But from last year we have started a program to reach to the community level. So this is ongoing process. So the progress till date that I will share. Right. So the project is enhancing psychosocial care for communities in disaster-prone areas of Odisha. Our basic objective under this program is to build the psychosocial care capacities at the community level, particularly to train the ASA, Anganwadi workers and our volunteers. Volunteers, we have different kinds of volunteers at the field level. Particularly in Odisha, we have a large number of task force volunteers, those who are present at the shelter level. In addition to that, we have also in 18 districts, we have Apadamitra volunteers also. So to include them, this is also one priority. And the other key objectives were to develop the knowledge products, particularly the training manual, participants handbook, because both in Odia and English, because when we are going to the participants at field level, we will be requiring the materials in the Odia also. Then create a pool of trainers, because these are the persons, because every time we can't ask for the national level institutions or the faculties to come to train at the field level. So with the support of organizations, we want to create a pool of trainers. They will serve as a trainer for the field trainings, as well as when we will intervene for larger disasters, they will also be team members, since they are the persons working at the district level. Then the another was the integration in the department level or the organizational level trainings. Organizational level means we are targeting the civil defense and the Indian Red Cross Society, Odisha State Branch, the training programs. So I told it is in first phase we have taken only 6 coastal districts. Then our plan is to expand based on the experience. We will expand it to the other districts also. Regarding the stakeholders that we have identified in the initial stages based on our first priority. So it is District Disaster Management Authority of the 6 districts, because the DDMA will be the key organizations who will implement the programs, and since it is headed by the collector himself, so it will be easy for us to run the programs. Then the key departments, Department of Health and Family Welfare and Department of Women and Child Development, because ultimately the participants are from belonging to these 2 departments, and the trainers we are also pulling from those district officials of those departments. Then other organizations like Indian Red Cross Society and Civil Defense Odisha. Then our key partner, knowledge partner, is the National Institute of Mental Health and Neurosciences, NIMHANS Bangalore. They have a dedicated department, DPSS, Department of Psychosocial Support in Disaster Management. And then OSDMA is anchoring there at the state level. So when we started, so initially, like yesterday we were discussing that since all the components are maybe similar, but state-wise or region-wise it will be different. Field level scenarios will be different. So initially there was a psychosocial need assessment prior to starting the program. So where officials from NIMHANS as well as from OSDMA, we visited those districts, 3 districts, 3 out of 6 project districts. And during this period, we have interacted with the committee members as well as ASA, Anganwadi, school teachers, volunteers, Apadamitra volunteers as well as other volunteers at the field level. Then also the health officers at the CSC level. This was done initially. Then based on the findings and discussion with the other departments also, then the modules and the materials were finalized or the drafts were finalized. Then we went for it to pilot training programs, TOT programs at the state level. These are the pictures of the 2 TOT programs that we conducted at the state level. Altogether, we already conducted 2 programs and 60 trainers already got trained from NIMHANS with the support of NIMHANS. Then if we broad categories of the trainers to the participants, it was the district project officer at the DDM level, clinical psychologist and psychiatric social worker, those working at the DMHP, mental health program. Then district ASA coordinator, right now they are saying that designation is assistant manager community process. Then district child protection officer and counselor at the DCPO. Those are basically 6 or 7 categories of the officials present in the training. Then other participants were civil defense instructors and our faculty members at the State Institute of Women and Children, because this organization is conducting regular programs of the training of Anganwadi workers. Then master trainers of DMTC, this is OSDMA trainers. So altogether 60 we have already created. So we are now our next step is we'll conduct the field level training programs with this help of these trainers, and based on the experience and learning we will move to other districts. So if we will go to the curriculum, this was basically whatever discussed during last day, all sessions. One is psychosocial first aid, that prepare, look, listen, link, those part, and the second is the psychosocial care techniques, 7 techniques. Then major component is working with vulnerable groups like women, children, persons with disability or old age. Then few sessions on the self-care techniques, because the whoever is the person responding to a disaster, she or he also needs that care. So this is for TOT it is a 4 to 5 days module, and for the field level training we have decided for 2 days, because since ASA and Anganwadi will be getting trained. So this is the initial stages. Once after completing the field level trainings, and then I can also share what are the challenges or what are the learnings that we will get.
Excellent, Dr. Mishra.
Thank you.
You did it in 7 minutes, so we are very happy. And you gave us a whole overview of what you're doing there. So thanks a lot. So we will request Kerala. So 7-8 minutes?
I will try, sir. I will make it in 7 minutes. Sorry, basically myself Zia, and I'm representing Kerala State Disaster Management Authority. So I'm trying to be calm amid chaos, because it's actually the role of Dr. Shekhar, and now I am acting his role. So actually Kerala has, that a lot of experiences regarding the disaster. Mainly we faced Oki, and recently Wayanad landslide, and also we have Kerala flood 2018, and coming year and the next year also we had faced. Due to the time limit, I will try to here present the Wayanad. Can you please show that PDNA? Like I shared a PDF. Okay. Coming to Kerala context, I'm working with the KSTMA only for 1.5 years. So I have that experiences. So basically, in KSTMA we have a trend that we share our experience to the next generation also. So based on that experiences, I am trying to articulate the or I am trying to present our experience here. So this is a PDNA. Everybody know that this is a post-disaster need assessment. So Kerala State Disaster Management Authority prepared this. We have a committee for this, and also while going to that PDNA, you can see that in detail we have given that how each sector is affected. Like how housing is affected, how public department affected, how schools are education affected, and how psychosocial affected. So while going through the PDNA, you can see, if you are interested, you can read that all thing, and if you are not interested to read the whole book, you have one suggestions that we have given a summary for that in the initial page. So you can understand while going through that how government respond to each sector. So first thing is that how each sector affected due to the disaster, and the second thing is that how the government respond to each disaster, each sector. So I want to go to the page number 2110. So okay. So in that we have a disaster happened, and we have formed we have government order issued under the head of the Social Justice Department. We have formed a community, and also our district mental health program coordinated that effort. And with that committee, in help of as our other SDMS represented, with the help of the Women and Child Department, Social Justice Department, and Health Department, with their collaboration, and especially our NIMHANS, with their help, we provided the initial psychosocial support. Okay, so then after providing the initial psychosocial support, you can see if there is a data in that PDF. If possible to go the page number 210 fastly, I can show you. Okay, fine. Okay, so in that, after giving an initial psychosocial, we have prepared a performa. So performa is basically we are assessing the psychosocial need of the affected community. The affected community means that the disaster always directly and indirectly affect the individual. So we assess that, and on the basis of the assessment, we have started to give the counseling. Initial PSFA were given to all the people. The people who directly and indirectly affected, we gave a psychosocial first aid, and after that we have give the counseling for some people need repeated counseling. So we gave repeated counselings for some people, and if you go to the data, you can see the percentage of people, and also some people require medical interventions like pharmacological intervention, the help of the psychiatrist. So they are also providing that. So in this camp, you know that after a disaster, the most of the people were in the camp, and in Kerala, other people were in their relatives' house. So in the camp, we know that the children are most affecting the disaster. So we means state government of Kerala, with the help of the Department of Women and Child, and also Department of Child Protection Unit, we have proposed a program called Kuttidam. Kuttidam means that space for the children. So we have create a space for the children there. They take up 114 activities that they have created a supportive and friendly environment to mitigate the psychosocial impact of the or psychological or impact of the disaster on the children. Actually, this Kuttiyadam is a prime example of the KSDMA initiative. KSDMA already initiated a program called or a project called Child Friendly Space in MPCS. I think everybody know multi-purpose cyclone shelters. So we have in 14 across district we have multi-purpose cyclone shelter. So in that shelter we are going to create a child-friendly space. Okay, so in my PPT it's there with our help of our architecture. We have do architecture intervention and the design, everything was in my PPT. So it is our aim is to that create a safe space for the children. So we started it. At first we have selected Kannur district in Kerala and at Kadirur Panchayat. So we are going to execute that things. So I think this is the way I
One
try.
sec, where is the PPT?
That's okay.
No, we'll just quickly go through the slides, no? How many slides is 100?
It's a lot of slides because actually
200.
this 40.
40.
40.
So we'll slip through when you showed us a PDF like that.
So
we must
if
see.
anyone interested, you can
Yeah,
share
I'm
or
very
else.
interested. Can we see it? So please go 1 second per slide. We'll stop you at the slide we want to stop you on. आगे करो, एक करो.
So go to MHPSS initiative by KSDMA.
एक करते जाओ. ठीक है, this is your overall
So
thing.
why it means MHPSS initiative means that the way forward we are. This is actually our okay.
Yeah, just keep going. We're getting a general
And
gist.
here,
Yeah.
actually.
Tell us about that. पीछे चलिए.
Okay.
Tell us about this.
Okay, next. Allah.
Next.
Okay,
Next.
fine. No,
Wait,
not like that.
पीछे. There. This one?
No, sir. There is some news report collage is there.
Next.
No, back. I think you have to go back.
Okay, go back.
Okay, here. So here I want to say that while in Wayanad, you may be aware about that as our Jaykumar sir yesterday said that we are rich in resource. When everything happened, we have lot of people will come, and I am getting call of, ma'am, you are a psychosocial expert, why you are sitting there, come here and you have to do like that. So we have a rich number of, as sir mentioned, that we have a rich number of people are there, but when we have a rich number of resources, what, as sir mentioned yesterday, duplication of effort will come. Because people are doing the same thing, and you said that people are going again re-traumatizing that, asking what happened to you, then you are okay, share something to me. So they are re-traumatizing that situation. So even your disaster news reporting, have you ever seen our Kerala news reporting? I don't know about you also, in your area also. We will say to that one kid and say, share your experience. Actually, what happened to your mother? Did you feel loneliness? So we are actually asking the trigger questions to the child, and they have the news value. I don't know. In fact, subconsciously we are also want that news in some way, because they are presenting it, and when we look into the view, they are getting more views in that such news values. So disaster news reporting is also important there. So when coming to so many.
Yeah, she will. I was waiting for her to finish this news part, because it's also important, because they have been publicizing what they do very well. And what she's telling us is a very important fact, because even we at NDMA need to learn that publicity is not something where you're showing your face, but it's something where you're showing your work so that it becomes a beacon for everybody else to follow. So that's a good example. So that's one. And next, ma'am, could you tell us about this Pariraksha?
Yes,
How did you make a cadre of counselors?
Yes, it's Pariraksha is actually in Kerala flood 2018. At that time, I'm not in SDMA, I'm only a student. But from getting the experiences from sir and also others, this is actually published in an International Journal of Risk Reduction. Dr. Kiran published this, our district mental health, state mental health authority nodal officer. So Pariraksha says, initially we have provided the psychosocial first aid with the help of NIMHANS and other teams we have provided. And later on, what happened is that demands increased and reported a lot of psychological issues. Yes, government of Kerala decided to develop a program called Pariraksha. Pariraksha means protection. full of protecting. We are preservation. So in this paridaksha, actually, as one of sir yesterday mentioned, that we don't want parallel other team. We have to strengthen our existing resources. So we don't want anything in parallel, and also we have a limit of financial and other issues. What we have to do, that we have appointed a paridaksha counselors for that project, and their qualification is that PG is required for them. And actually what the role of these counselors is that, we already had ASHA members, and these ASHA members will provide the psychosocial first aid. And in that psychosocial first aid, how will they understand that? They will give some, we will train them how to ask. That's important. So yesterday we mentioned that everybody can give what? PSFA, but we have to ensure that minimum we should attain a training. What is PSFA? What is PSFA is not? The language we have to use them. So everything we should train that. So ASHA workers got training that, and they are going to the home visit, and they will ask the simple questions. And if they find anything, the more required services, they will refer to the counselors. And also if the people feel any distress, they can directly come to the counselors. ASHA workers got training from the counselors. So another thing is that our in that framework, third one is that primary health care giver. So our primary health care giver is that in our PHSC we already have primary physicians, but they don't have any training on what disaster. They are good in treating the people. That psychiatrists are treating, or that primary care physician are good in treatment, but they don't have any experiences how to handle the people who affected the disaster. So they are giving that training. So if the people require more medications or something, we are referring to them as the primary care physician. And also not only psychiatrists, we created a mobile mental health well-being unit. It means that we have one clinical psychologist, psychiatric social worker. So both the system, what I am trying to communicate is the referral system here. Okay, first ASHA worker is there, and ASHA workers are going then, and then counselors. And also counselors doesn't mean that ASHA workers, first the people affected what I'm trying to this, that counselor can also directly involve in that. So first is ASHA workers referring to counselors. So counselors, if they need more treatment, they will help refer to the primary health care and also mobile health unit. And the same time, what we have to think that I have experiences that in that, okay, when we going into people, they won't, at first they won't say any their psychosocial needs. They will report that, they will say that I lost my house, I want house, so I need this. So how will that, we will reduce the distress. So we need that intersectoral department collaboration. So referral system is not only always ASHA counselor, not always like that. We have to know the knowledge of what were the government programs is. So if they lost their house, how many amount they will get, where they have to go. So ASHA workers should also be trained for that. So referral system is not always this step to care approach, because it's also the way that we need intersectoral collaboration also. So I think you got some takeaways from my presentations. So if you have any doubt, you can ask.
Thank you, ma'am. Thank you. Yes, now Dr. Abhishek, so you can please. She came from Kerala on an express train. She hasn't yet got off.
Thank you, sir, for giving me this opportunity. Myself, Dr. Abhishek, presently working as a first responder, rescuer in 16 Battalion NDRF. So, being a young lad, or I can say I'm in a state of learning, so I will try to convince you all with all our experiences. And so from day one to this time, so many valuable informations has been shared, but I will only focus upon the role of NDRF and our experiences, and along with that few recommendations from NDRF to the other stakeholders, to NDMA. Next. Okay. So this one is my first experience during the Kerala floods, as Zoya ma'am said. So this small picture was made by a 5-year-old child when we were working in Pathanamthitta district in 2018. So just मैं ये जानना चाहता हूँ कि आप लोगों का क्या सोचना है इस पिक्चर को देख के।
ये फोटोग्राफ है
सर, ये फोटोग्राफ है, एक ड्राइंग है छोटा सा, एक 5 साल के बच्चे ने बनाया था when we were working in Pathanamthitta district.
ये
आप
ज्योति,
क्या
you have
सोचते
any comment? What do you see in this?
I only feel a lot.
What?
Like, what a lovely way for a child to express, no? Because they don't have too many words, but then they can think of the house, they can think of the flowers, they can think of the greenery. Look at the painting, the front door, like it is just the image of the house. And that has a lot of meaning for a child.
I see a trunk.
You see a
I
trunk?
see a box.
Yes,
So
ma'am.
it's written
house is in a box.
it's written मेरा घर. and
और ये एक और चीज़ है, केरला हैज़ अ लॉट ऑफ माइग्रेंट्स एंड आई थिंक ये इसने हिंदी में लिखा है, तो ये वहाँ का मूल निवासी नहीं है, तो उनकी भी ज़रूरतें हमको रखनी है। ये एक बहुत अहम बात निकल के आती है इस पिक्चर से जो मुझे दिखती है।
Actually, केरला में आई थिंक हिंदी सेकंड लैंग्वेज, आई थिंक। मुझे ऐसा मतलब आई मे बी रॉन्ग, बट
I think
I may be
Arabic
wrong,
is
but
second language.
that picture was made by that केरला का ही बच्चा था, means he was from Kerala only. So this painting was made just 2 days before the flash flood. So we just saw that picture and we felt that pain and grief which जो उसने अपनी
days
पेंटिंग
after.
में उकेरा था वो हमने
2 days after the flood.
2 days before the flood, sir. And he kept, उसका जो घर था वो आई थिंक बह गया था और उसने अपने पास ही रखा। वो पेंटिंग थोड़ी सी आप देखेंगे तो भीगा भी हुआ था, तो हमने क्या किया कि उस पेंटिंग को उठाया और मतलब हमने एक तार में उसको बांध के हमने सुखाने की कोशिश की, सो डैट कि वो पेंटिंग रहे। So this is the one way to attach, you know, during a rescue, during a response, during a any disaster relief. तो एक ये भी तरीका है साइकोलॉजिकल काउंसलिंग का, साइकोलॉजिकल फर्स्ट एड का, which we had given to this child. Then providing medical first aid, providing आई कैन से रिहेबिलिटेशन पार्ट ऑफ पे जाएंगे तो शेल्टर्स प्रोवाइड करना, उनकी बेसिक नीड्स, फूड्स का प्रोवाइड करना। एक मिनट ये फोटोज़ पे रोकेंगे, बैक पीछे जाएंगे तो ओके।
यहाँ पे
तो केरला की स्टोरी ये थी बेसिकली। कोविड-19 आई थिंक 90% ऑफ पीपल, सभी लोग अफेक्टेड हुए होंगे केरला की कोविड-19 में। ये कोविड केयर सेंटर की फ़ोटो है जहाँ पर एक पेशेंट को हमने ट्रीट किया। देन दैट नोट वाज मेड बाय दैट पेशेंट, एवरीथिंग इज रिटन इन दैट नोट फॉर अस। द मेन पार्ट इज दैट सपोर्ट। नाउ वी आर टॉकिंग, जो अभी हम बात कर रहे हैं यहाँ पे कि साइकोलॉजिकल सपोर्ट की बात कर रहे हैं, तो मेडिकल एड देना या फर्स्ट एड देना या फिर कोविड के समय में जो काम किया गया उस समय जो सपोर्ट मिला, वो भी एक तरह का साइको सोशल सपोर्ट होता है इन द फॉर्म ऑफ, यू कैन से कि मेडिकल केयर। फिर तुर्की में आपने देखा जो NDRF का रोल था ऑपरेशन दोस्त के समय। ये फोटोग्राफ काफ़ी फेमस हुआ था तुर्की के समय जब हमारी टीम वहाँ पे गई थी। 6 साल की बच्ची को बचा के लाना, रबल के बीच से निकाल कर लाना, और एक सिंपल हग जिसे बोलते हैं कि ना हिंदी में प्यार की झप्पी, वो भी एक तरह का साइकोलॉजिकल सपोर्ट है। जस्ट मैं ये आपको कोशिश कर रहा हूँ कि समझाने की कि कई तरीके हो सकते हैं। शेल्टर प्रोवाइड करना, फूड सप्लाई करना, बाकी चीज़ें जो बेसिक नीड है प्रोवाइड करना, ये पार्ट है साइकोलॉजिकल फर्स्ट एड का। नेपाल अर्थक्वेक की बात करूं तो आई वॉज अनफॉर्चुनेटली नॉट देयर, बट हमारे जो सीनियर्स सर पीछे बैठे हैं, वो हमारे सीनियर्स बैठे हैं तो वो बताएंगे। उनका कहना था कि एक इंसिडेंस ऐसा था कि नेपाल अर्थक्वेक में लोगों ने ये कहा कि अगर आप हमारे रिलेटिव्स का, विक्टिम्स की डेड बॉडी ही अगर आप बाहर लेके आ जाओगे, वही हमारे लिए सब कुछ होगा, वही हमारे लिए एक मोरल होगा, वही हमारे लिए एक साइकोलॉजिकल सपोर्ट होगा। तो रिट्रीविंग those dead bodies in Nepal earthquake was also a we can say ki type of psychological support to those victims. Then the same thing happened on that 27 January 2025. I was directly involved in that operation. और एक जो मेरी रिकमेंडेशन रहेगी, जो मैंने पता किया कि पोस्ट डिजास्टर लाइक बिल्डिंग कोलैप्स इज ऑल्सो ए टाइप ऑफ ए डिजास्टर। तो बुरारी के केस में जो हमने फॉलोअप करने के बाद जो पाया कि वो बिल्डिंग जो थी वो आई थिंक अंडर कंस्ट्रक्शन बिल्डिंग थी, 5 मंजिले की बिल्डिंग थी, बट अंडर कंस्ट्रक्शन बिल्डिंग में जो डेथ हुई वो लेबर्स की हुई, वर्कर्स की हुई। तो रिहेबिलिटेशन पार्ट में कहीं ना कहीं हमें सोचने की ज़रूरत है कि हम कैसे उनको रिहेबिलिटेट कर पाएँ। अभी 2 दिन पहले जो भी सर्वाइवर्स थे उनसे जब मैंने बात की तो पता चला कि वो दिल्ली छोड़ के जा चुके थे। तो ये चीज़ें हमें देखनी होंगी कि ये हमारी जो लूप होल्स हैं, जो गैप्स हैं, इसको हम कैसे फिल कर सकते हैं, कैसे हम रिहेबिलिटेट कर सकते हैं। वो सिंपल एक वर्कर थे, वो उनकी डेथ भी हुई, उनके रिलेटिव्स ने वहाँ पे जान खोई। हमने लगभग 11 से 12 लेबर्स को हमने बचाया और 6 या 7 डेड बॉडीज़ को रिट्रीव किया। तो ये जस्ट मैं ये बताना चाहता हूँ कि इस तरह के केसेस में जहाँ पे बिल्डिंग कोलैप्स के केसेस होते हैं या अंडर कंस्ट्रक्शन बिल्डिंग जहाँ पे लेबर्स होते हैं जो परमानेंट रेजिडेंट नहीं है यहाँ के, उनको हम कैसे रिहेबिलिटेट कर सकते हैं। सो समटाइम्स आपको ये फील होता होगा कि हेल्पलेस, बट सपोर्टिंग अदर्स इज़ अ वे। These are the skills। मैं कुछ उस पर बोलूँगा नहीं क्योंकि ये मेरा डोमेन नहीं है, बट मैं कुछ रिकमेंडेशंस चाहूँगा। जैसे कि पीस टाइम में जब NDRF अभी जैसे वी आर इन पीस टाइम, अभी कोई ऑपरेशन नहीं है, तो हम क्या करते हैं? हम करते हैं कि हम SDRF या NYKS या फिर जो हमारे कम्युनिटी अवेयरनेस प्रोग्राम्स होते हैं, टेबल टॉप एक्सरसाइजेज होते हैं, फैमिलाइजेशन एक्सरसाइजेज होते हैं, हम डेमोन्स्ट्रेशन देते हैं, लेक्चर्स देते हैं और स्कूल सेफ्टी प्रोग्राम्स करते हैं। तो साइकोलॉजिकल फर्स्ट एड की कुरिकुलम को अगर उसमें शामिल किया जाए तो बेटर होगा। नॉट ओनली मैं कल सर से भी बोल रहा था कि SOPs, मॉड्यूल्स और ये सारी चीज़ें तो ठीक हैं, बट हम क्यों नहीं इसमें फेमिक्स में शामिल कर सकते? हम क्यों नहीं इसको अपने NYKS के प्रोग्राम में शामिल कर सकते? जब हम SDRF को ट्रेनिंग देते हैं, NDRF जब ट्रेनिंग देती है, तो हम उसमें जो कैपेसिटी बिल्डिंग प्रोग्राम्स करते हैं उसमें हम इसको शामिल कर सकते हैं। तो हमें भी डायरेक्ट किया जाए, हमें भी एक कुरिकुलम प्रोवाइड किया जाए। इवन जब मैंने NDRF ज्वाइन किया था तो हमारा भी बेसिक फर्स्ट रिस्पॉन्डर कोर्स होता है 19 वीक्स का। इस 19 वीक के BFRC कोर्स में कहीं भी साइकोलॉजिकल सपोर्ट या साइकोलॉजिकल फर्स्ट एड की बात नहीं होती। तो आई थिंक NDRF में भी BFRC के लेवल पे ये चीज़ अगर शामिल हो तो हमारे भी रिस्पॉन्डर्स, हमारे भी रेस्क्यूअर्स जो हैं उनको हेल्पफुल रहेगा. देन इन केस ऑफ एनी कोई भी ऑपरेशन होता है, कोई भी डिज़ास्टर की कोई भी ऑपरेशन होता है जिसमें कि एनडीआरएफ का डायरेक्ट इन्वॉल्वमेंट होता है, चाहे वो इंडिया में हो चाहे आउटसाइड हो, इसमें और भी स्टेक होल्डर्स को शामिल किया जाए, जैसे निमहैंस है या फिर WHO है या यूनिसेफ है. उसमें हमारे साथ अगर वो क्लब करके काम करेंगे, पर्टिकुलरली दिस ये साइकोलॉजिकल सपोर्ट या साइकोलॉजिकल फर्स्ट एड पे, तो वो हमारे लिए ज़्यादा कारगर होगा ऑन ग्राउंड जब हम काम करते हैं. तो देन एक और भी रिक्वेस्ट होगा कि साइकोलॉजिकल सपोर्ट टीम जो एनडीआरएफ की एग्जिस्टिंग टीम्स हैं उसमें हमारी कई टीम्स हैं, जैसे CBRN टीम्स हैं, सर्च एंड रेस्क्यू टीम्स है, वी हैव फ्लड वाटर रेस्क्यू टीम्स, वी हैव CBRN टीम्स. तो इसी तरह से अगर साइकोलॉजिकल सपोर्ट टीम हो हमारे पास, तो हमारा जो काम है, जो हमारा वर्क है, वो ज़्यादा ईज ऑफ हो जाएगा. देन इम्प्लीमेंटेशन ऑफ मानस पोर्टल, एक और रिकमेंडेशन है कि इम्प्लीमेंटेशन ऑफ मानस पोर्टल अभी एनडीआरएफ में, आई थिंक एनडीआरएफ में ये नहीं है, तो इसको भी अगर इम्प्लीमेंट किया जाए मानस पोर्टल को भी, सो दैट कि हम अपने जैसे देवदूत ऐप है हमारे पास, हम कोई भी ऑपरेशंस करते हैं, कोई भी इस तरह के रिस्पांस करते हैं, रिलीफ रिस्पांस करते हैं, तो हम देवदूत ऐप का इस्तेमाल करते हैं. बट मानस ऐप का अभी इस्तेमाल नहीं हो रहा है, तो मानस ऐप का भी इस्तेमाल एनडीआरएफ में होना चाहिए. देन डिजिटल टूल्स कुछ अगर हो अवेलेबल हो सके फॉर एनडीआरएफ, सो दैट कि ऑन ग्राउंड जो हम काम करते हैं, जो रेस्क्यू रिलीफ का वर्क करते हैं, वो ऑन ग्राउंड हम उस टूल्स का इस्तेमाल कर सकें फॉर MHPSS. देन सर लास्ट एक फ़ोटो से ख़त्म करूँगा कि कोऑर्डिनेशन, वी नीड amongst people that coordination and stakeholder to extend mental health support to the vulnerable community, just like अगर आप ये पिक्चर को देख सकें, महसूस कर सकें. तो that's all from my side, sir.
Thank you, that was great. So what you basically told us was that there is a phase before the MHPSS experts can come in, and that phase is when the actual saving is going on, the actual response is happening, and people are being pulled out of buildings, pulled out of their flooded homes, or extracted from a caved-in set of earth through a landslide. So that is a stage where you can do some instant assistance, like that little thing you showed about the photograph. If you hang that photograph, it sends a general message in the people who have just been saved, who are in that area. They can see that at least these people who are rescuing us have some care for our belongings. And even if you're not able to save their gold and their jewelry and their precious land papers, at least that one little picture was good enough, and it would have offered a lot of support to them. And that word you mentioned, support, in that COVID letter. So that these were very good examples. This is the reason why we wanted NDRF to be here, and we've got the NDRF DG for our closing session for the valediction for this very reason. Because they may not be the really first responders. The first ones may be the state police, the district police, the home guards, the volunteers who exist in that tehsil or in that district, and they are the ones who will also see and learn. So it's a very good exercise. Thank you so much for your intervention. I would like to start with you, Abhishek, and ask you that have you been to the Turkey thing or the Myanmar?
No, sir.
You didn't go to either of these. So which of the spots have you been to yourself?
Basically, sir, Burari
Burari here?
वाला केस मेरे सामने हुआ था.
Outside Delhi?
आउटसाइड दिल्ली सर, दैट केरला फ्लड्स मैंने पार्टिसिपेट किया था.
हाँ.
एंड छोटे छोटे ऑपरेशंस में जाते रहते हैं विद इन द दिल्ली, बट नॉट मेजर सर. अभी तक कुछ ऐसा पार्टिसिपेट नहीं किया.
Okay. Not a worry.
हमारी टीम्स ने पार्टिसिपेट किया, तो उनके जो लर्निंग्स, उनके जो एक्सपीरियंसेस है वो मैं शेयर.
So when the DG comes, then in our opening remarks we'll make a mention about the fact that this whole body of people, experts, think that in the 19-week course of NDRF, we should include psychological first aid as a small, maybe 2-3 courses in that 19 weeks. All of us are agreed. So with your support, I can tell the DG NDRF this.
Excuse me, excuse me.
You have
It's a very big salute I will give the RBF people. So they are making a bridge within half an hour. That is appreciable. So the people are very much suffering. The flow was very high. So half an hour they have to making a constructive bridge, and there's the support. I will give the big
Thank you.
salute.
So the secondary role is to make a bridge to the mind also.
Okay.
So we would like them to do that as well. So that's a very good suggestion that is coming out of this. So Dr. Mishra, do you have any suggestions to add after listening to all the interventions and what we discussed yesterday? Do you have any suggestions on what we should do? Like everybody says there are a lot of guidelines. So,
Sir,
aapne bhi
sir,
padhi hongi
if it is the
guidelines.
right time, if one or two suggestions.
Yeah.
Yeah, thank you. Thank you for interruption. I'm working with the people with disabilities. I worked during my service as Deputy Chief Commissioner as well as State Commissioner Disability, and I have gone through the Kerala State Handbook on inclusive DIRR. What I find, one important thing, whatever resources that we have in our website or online, these have to be completely accessible to people with disabilities, which are not fully today. There is a Supreme Court order and also the Chief Commissioner for Persons with Disabilities that all the websites, all the documents have to be accessible. I have gone through the website of NDRA and NDMA and others. Excellent documents, excellent information. There is also a document, handbook on DI-DRR. I find little challenges to access that, particularly by people with blindness or other people with disabilities. Yes, we in the disability sector would be willing to come forward and help, collaborate, and do that. One. Number two, that counseling, the CVM India Trust worked in Sundarbans, Assam, and Kerala, and all. So one observation they found is that psychosocial issues and counseling that is available, we look for it very late. It has to be, of course, a continuous process, and also to make them resilient, strong enough, children, and particularly people with disabilities or children with disabilities, women with disabilities, the cross-sectionality is so important, more affected than anybody else. So before and immediately after that, first aid. And then third point I want to make is the training part of it. Training part of it, that SOPs for the people on ground. And as it is there in the RPWD Act, in the guidelines, we do not have the mention of Rights of Persons with Disabilities Act 2016. It should be. Probably our 2019 guidelines are due for review. We should review and include people with disabilities. So District Disaster Management Authority is mandated to have the number of people with disabilities, their details, etc. in the district. So that will help us.
Thank you. Thank you. That was nice. Before I come to you, Dr. Mishra, just 1 second. So you mentioned a point about the aid reaching to them a bit late. But just yesterday, Dr. Jay Kumar was telling us about how he had 250 NGOs reaching Wayanad, and they had to restrict entry of NGOs. So one little thing I was discussing with Dr. Krishnavats today, we work beyond hours also. So we were discussing just this morning. See, morning, afternoon, night, we are working. We are such dedicated people. So in the morning, we were discussing that very point, that already there's a huge resource of skilled manpower resource which is available post-disaster, maybe much more in Kerala, but maybe less in places like Sikkim and others. But how do we channel this? How do we archive this? That, I think, is more of a challenge. And how do we do this resource mapping if you remember, one of the little 5 recommendations we had made in the first presentation was resource mapping. So is there any idea you have, Dr. Jay, on resource mapping? How should we go about it? Are there already some resources? We can bring those 3-4 organizations together and put it all together.
Sir, that's a very pertinent point. Now, the ministry has asked us to come up with a real-time bulletin board of all those resources, both manpower and infrastructure available during the disasters and non-disaster time also. So NIMANS is working on that, putting across. Actually, first we are focusing on the government side. And I think, I mean, we need to discuss with Krishna Sahab to actually make it actually much more broader for all the areas. I mean, the corporates, the spiritual organizations. So I think this actually needs to come up actually in a point of a time, which we discussed with him last time also when we had a meeting.
So it's
for the
decided now, let's do it.
It is not there, sir. It is not there. One.
Let's do it.
Second is, sir, 2 more observations. We work with NDRF from the academy to most of the operations. We do actually post-disaster sort of stress management and well-being, this one. Now there is actually a request has come from the academy from Nagpur for us to actually integrate, which Dr. Abhishek was talking about it, to integrate this into their curriculum. That is actually one thing which we are looking at it. Second is, there is actually also a request has come from BPNRD, Home Ministry. We had a meeting last month to come up with actually a module for entire police force of this country and CAPS. Although we work with most of the CAPS and police forces, but now there is actually a specific uniform that this one has come. So Additional Secretary, Home Ministry and BPNRD, this chairperson actually asked us actually to come up with a proposal actually to covering, which you, sir, you were talking about home guards and police, because these people reach before the NDRF or SDRF comes.
So that's an extremely good point.
Yeah.
BPRND has been asking us also.
Yeah.
They've asked us for 2 things. One is this.
Yeah.
So since Ministry has already instructed,
Yes, sir.
we won't get into that. Please do it. And if you want our help,
Yeah.
we were there to help.
Definitely.
The other thing that BPRND wants is about 4 or 5 experienced persons of whatever kind of skill
Right.
who can help them question people. I'm using very polite terms for interrogation, but there are, I mean, how to question people. So that's a kind of separate query, completely different from this workshop.
Yeah.
So we will talk about that.
Yes, sir.
So a resource map, you say that you're already building a real-time bulletin board.
Yeah.
Now there is a real-time bulletin board built by NIDM and NDMA called IDRN.
Yeah.
It is for equipment. So NDRF has access to that. Many state polices have access to that. So they look at it, okay, where is the closest chainsaw in. Okay, so you said sorry, so now we know whose phone that was. So, so at times you should never confess. So, we must work on it, and we can do it quickly because
Yes, sir.
nobody is going to wait for this.
Yeah.
It is something that needs to be done. So anything you need, don't discuss. Let us call and say, I want this, and
Yeah.
we'll help you get
Yes,
it.
yes.
Okay.
Nice. Yeah. We will come back, sir.
And our
We'll come back.
MOU, consider it signed.
Be signed. Oh.
So that's a good second point we've got, that the training curriculum of first responders like police, home guards and others, NDRF training thing, a real-time bulletin board. That's 3 very good recommendations. Is there anything else that we should, Dr. Mishra, take away from this?
2 points. One is coordination from the beginning. Since many times it happens that one department or one organization will conduct the programs and implement the thing, and the other department is not knowing. So at the end, it will not be fruitful. So from the beginning, if we are coordinating and collaborating, then when we will be at the time of use, actual use, then everybody will be aware that these are the resources available with different organizations, or these are the things that already conducted, and we can carry forward. I will give you one example that when we started, initial discussions, it was 2 persons from the DMHP. Then I asked the Additional Secretary at the Mental Health, at the Department of Health and Family Welfare in our state. So she then replied that other persons are also there, those who can be trained in future, like community health workers at the health officers at the CSC level. So these kind of information that only department people can give you. So from the beginning, if coordination and collaboration is there, it will be better implemented.
Thank you.
And regarding the guidelines and the manuals, that point, because we are at the implementing end, so whatever the guidelines already finalized or what are the modules are available, we have to implement that. And we have to give simultaneously feedback to the national authorities regarding what is working well and what are the problems there in the implementation, so that in future they will rectify it. So first thing for us, it will be implemented first based on our infrastructure and organizational setup. Then we can give feedback, and based on that they will review and rectify it.
Thank you, thank you. Anything from you, Dr. Manohar?
I think we can include, we had Yuva Apta Mitra Master's Training Program. So the psychosocial support modules can be included in the Master's Training Program.
We'll add that, yes.
That's one thing. So that, they're expected to train the community-based volunteers. So in that way, we'll, reach out.
Good, we'll include that.
And very simple field operation manual on psychosocial support. Right. I think that would support.
So you're going to help us make one?
Yeah, sure. Sure.
Simple field operations manual. Okay, so
just kind of a pocket diary.
yeah, great. So if you can put up that main screen, just one second, Jyoti. Main screen, so I'll just show you this thing called coder. What is this coder? So there is this coder 11 written over there at the top. Main screen mein dikhaiye. So this coder 11 is what? It is CODRR, is Committee on Disaster Risk Reduction. So we figured out when we kind of 2-3 years ago that something needs to be done about exactly what Dr. Mishra said, ki coordination mein problem hai. So we found that this ran across all hazards, whether it's earthquake, whether it is coastal hazards, erosion, or cyclone, monsoon, whatever. There is a problem of everybody talking to everybody, not because people don't like each other, which is a normal thing, but because people are generally hesitant or they do not know the other person on the other side is. Occasionally you get a rebuff when you call somebody, so you don't want to call up the entire ministry after that. So, and then the state center, then the state to the private, then the center to the private, state to non-profit, all those issues were there. So we created this coder for every hazard. So we are now running at number 11. So we've got 11 such coders. Some are very hyperactive, some are slightly less active, some are inactive. This is the first meeting of this one. So we would in fact request Dr. Ghanishta Suri to, she is also hyperactive. I think she has ADHD, the H part is most highlighted in her. So she will basically reach out to some people specifically, and we'll keep having these regular coder meetings online so that you don't have to waste time coming to Delhi or to headquarters. You can do it from your desktop, and we will discuss these issues. And the whole focus is to take things forward, and paperwork should be secondary. Okay, so that's the general idea. Let's try and do things fast because a lot of paperwork has been created. Simple field ops manual, we'll make Dr. Manohar run the person. He must have read all of them by now. And if you can start drafting one, a two-page, focus on 2 pages, bullet points. Like these are the 5 things you can do in PFA. Okay. Anything else? Anybody? I want the young students from Daulat Ram College to tell us some of their experience, that what do they think about us? You have a very soft voice, so please get closer to the mic.
Okay, so listening to everybody's presentations here, I mean, personally, I'm not from a coastal region. I come from Madhya Pradesh, Bhopal. So, like, floods are not a part of our city, something that I haven't experienced, but these problems are real, as Abhishek Pandey sir really highlighted, because he works with the ground level people. People were also talking about timeline and coordination. So first responders, I was discussing with my friends here that a lot of the problems with the first responders here is that psychosocial support ke liye, there's no protocol, like immediate protocol. But sir has also mentioned that there are rich resource people that are there, and they need to be restricted also, because so many NGOs, they reach at the spot and there's no coordination on how to help. So maybe if we try to understand or make the people train in how these problems, like problems faced by people might be like anxiety or PTSD, or unable to like enterprise the situation that they're facing, grief, loss of household, loss of like work, people, even lives. If we understand how these like things work, and what is the thing that is most affected to the people who are facing anxiety, PTSD, or grief, then maybe we can come up with a better like coordination on how to get people to first responders to respond to these people and their needs.
Great.
That is something that I understood from that.
Thank you. So you'll be getting 5 extra marks for class participation. There was a hand
Thank
up
you.
there somewhere. Yes, please.
Thank you, sir. My name is Vishal. I'm from UNICEF. And I have many suggestions, but I'll like to highlight only 2. These are based on my experiences of responding to various disasters. So one is the respectful care and treatment. So I would like to put a suggestion that through NDMA, if Ministry of Health and Family Welfare, if it is told that all their modules of training should have this component. So these are the people who are on the ground, your ANMs, your doctors, and because of that influx of the people, they also get burnout and all that. So if they do this respectful treatment, that's a first step towards the psychosocial support. People feel happy, like, okay, I'm safe now. And if the doctor speaks you in a very good language, or a paramedic, that's something which gives mental relief. And second is,
So
sir,
just
now,
1 second.
nowadays...
So do you have this, any feedback in NDRF that your jawans are giving respectful treatment or irrespectful treatment? Do you get complaints कि ये बुरी तरह से बोल रहा था and all? Because in my IPS officer experience, in a situation where there is grief, those 5 stages of grief are in their first stage, I have seen policemen to be very kind and supportive, very different from the way they normally are in their regular duties. So I don't know, do you agree with that?
Actually, that manpower, crowd management is not our domain actually.
No, not crowd
Basically, we are dealing with rescue and relief, but I've not heard about that ki any...
There are no such complaints.
Nas
Okay, so there must be something in the middle. Your experience says that there is disrespectful treatment.
Sir, naturally, because they are working day and night, these people who are sitting in the relief camps or their duties, they also have their homes to look. Most of the people are from the same area which are also affected.
Okay, great.
So that's something which I want to...
Truth is always in the middle. We will figure that
Yeah.
out. Thank you.
And
for
the second one is the media training. Because nowadays, in earlier previous disaster before 2010 or something, social media and everything was not there. But now it is very, very prominent. So there should be some SOP or some guideline telling what to report. Then examples should be taken from Japan, how they do that. Thank you, sir. I rest my points.
Thank you. That's interesting. Yes, and anybody? Yes, Jyoti, yes, ma'am. Sorry, you're the boss and you're not.
No, I just wanted to quickly add 2 points. First is suicide prevalence. That is something, as we've been talking about mental health and psychosocial support. In disasters, the risk for suicide ideation or attempts are pretty high and escalated. So to kind of look at that also in terms of SDGs for mental health 3.4, we do look at suicide prevalence at a country level to look at the, it's like a thermometer for how the mental health of the country is. So that will be something that is important. We touched upon this briefly yesterday, and also my colleague Vishal, what he was talking about. Do no harm is a very primary principle for doing mental health and psychosocial support work. Harm can be defined very differently. One can be just very obvious aggression or being disrespectful or rude. Sometimes it's what we've heard about, very intentional volunteers who really want to help, but they don't know how to do it. So they may end up, or even the media really wants to amplify the story of distress, so it really catalyzes action, from the side of people who are, reading these or listening to these stories. But then they are done in unintentionally harmful ways. I really want to connect this to the master trainings that we've been speaking a lot about, training of trainers, etc. One question is, when the training of trainers are happening, how effectively have their competencies been increased? That knowledges may increase, that's very easy to look at a questionnaire and, questions and answers. Skills also, it's quite easy. You can just ask them, in this situation, what will you do? But a competency is when the actual situation is happening, can I recall this and can I exercise the skill that I have? So competency-based trainings is something that we are really kind of moving towards as a paradigm in how we train. And also kind of having a structure to how the cascade trainings are happening. Because if we have any evidence, it's really that cascades are a bit, touch and go. The coin can fall on any side and it may or may not be effective. But then to really, and that is the modality that we have, especially in a country of this kind of population, we have to rely on cascades. We have to trust that the people that we are training, the cadres, are capable of building local capacities. But then we also have to enable them so they know that these count as intentional or unintentional harm, and basis that I'm capable of training groups of people, whether they are specialists or non-specialists or volunteers or young people, to deliver MHPSS care that is highly ethical, and you can consistently expect high quality.
Okay, great, thank you. Anything else at the backbenchers? Yes, ma'am.
Good morning to all present here. My name is Dr. Shelly and I'm from Brook, India. So, because today we are talking about case studies from the states and the roadmap ahead, I want to actually highlight the role of livestock species. Because we know that the livestock species, they are the major source of livelihood for the marginalized communities. And livelihood recovery is the, we can say, key factor for the psychosocial resilience also. So do we think about their rescue and rehabilitation of these livestock species of the marginalized communities and the people affected?
Yeah, your team made that point yesterday as well. And again, what I have seen or heard in my entire career is that saving the livestock is more dependent on the human beings being saved. And most of the time, the livestock always comes first for that person. Normally, a pet comes first. And then if there's a large number of livestock, then a lot is done by the person himself or herself. And then the rescuers also assist them. But as a concerted way of thinking, I agree with you. We need to put some thought into this and maybe put it into training, that our police people or whoever goes to help at that spot, they should generally keep an eye that if a person is saying his livestock is important, yes. But then if you're taking a boat which has place for just 7 people, you may not have place for heavy livestock. So all those issues come with responders. That's a big issue.
Because retaining livestock that gives individuals hope and purpose, which is essential for the psychosocial support.
मैम बेसिकली मैं एक आपको इन्फॉर्मेशन देना चाहता हूँ कि वी हैव VFRC बेसिक फर्स्ट रिस्पॉन्डर्स कोर्स. उसमें हमारे को एक करिकुलम है हमारे पास जिसमें हम लाइफ स्टॉक को कैसे सेव करें, लाइक एनिमल रेस्क्यू का भी एक चैप्टर है. तो मैं आपको एक बताना चाहता हूँ कि नॉट ओनली ह्यूमन, हम ड्यूरिंग द डिज़ास्टर लाइफ स्टॉक को कैसे सेव करें, कैसे रेस्क्यू करें, उस पर भी वर्क करते हैं. नॉट ओनली द लाइव स्टॉक्स, इवन आपको मैं बताना चाहता हूँ 2 दिन पहले दिल्ली की ही घटना है कि हमें एक डिस्ट्रेस कॉल मिला कि किसी का पेट, एक कैट जो कि कहीं मेन होल में गिरा था, तो हमने उसको भी रेस्क्यू किया. तो नॉट ओनली द लाइव स्टॉक, किसी भी तरह का कोई भी जीवन है, कोई भी है, तो उसको हम रेस्क्यू करते हैं. तो it is our part, it is our like part of our curriculum. So we are involved in these things.
Thank you.
Sir,
So we have a last question, last comment. All of you together. One second. Yes, please. Second last. You're last. Yes.
Yeah.
So, building upon what basically everyone said, I'm going to pick things from here and there and just cluster it up together. So, I'm from Patna, right? And there's always a flood-like situation after like 3 days. It rains in there. So, like there was this 2019-2020 flood which occurred, and we were in a situation that even we could not go and get our groceries. Like everything had been in the water like by then. So the thing that I noticed was mostly that a lot of help and people who used to come, who used to anyone and everyone, they were also restored. But the people who were at a position of privilege, such as myself, sadly, we turned a blind eye towards them, because how could we help? We cannot really descalate from our 15 floor apartment buildings. I mean, there's no 15 floor apartment there, but still like 5 floor building, and no one is willing to help anyone. Earlier today, there was this thing mentioned that even the rescue people are kinder to people when it comes to, such a scenario. But in those 7 days of rain which was going on, maybe it's just my state, but people were very selfish, and even those who were very privileged were hoarding their resources. No one was willing to help anyone. And it's just, it again, it could be regional, but then I would just say that there should be awareness in states where there's no awareness about it. There should be, there should be an initiative taken to, make people aware that someone who needs more than you should be provided with it.
That was a very good
So,
point, very
yeah.
good. Thank you. You're not very happy with your country cousins, huh? Yes, last point, please, because we have to end. Pam,
Yes, sir.
let's-
Good afternoon, sir.
Okay.
Myself, Dr. Dinesh Singh Rathore.
Yes, please.
I am from Institute of Mental Health and Hospital, Agra. So I would like to share some my experiences from flood and cyclone in Gujarat. First thing I will like to share that as you mentioned, that there is a grief reaction. So in the grief reaction, the person who is suffering from the loss, they will come with the anger, denial. So the person involved in the relief work, they should be oriented about the normal grief and psychological support. Otherwise, there will be protest and anger against them also sometimes. Second thing is religious coping. So each and every community there is having very good religious support system also, and beliefs. So in Gujarat, where some bodies we didn't find, so there was a psychological support by just mocking a community cremation, collective cremation, and doing all rituals of cremation, so they can express their emotions in the community. So they will come out of that grief reaction. Third thing, that victim of disaster are the normal people in abnormal situation. So any normal people landing in the relief work, part of the task force, should also be oriented and well-equipped, well-trained about the psychological support system. Screening of the person involving in the relief work should also be there. If somebody is sensitive towards any mental health problems and involving in such task, may land it up in psychological distress also. Thank you.
Thank you. So now we have one last question after the last question. Yes, ma'am. Okay, there's a last question after your last question.
Yeah. Thank you, sir. And good morning, everyone. So I'm a researcher, and I want to share my perspective since the Patna case has come and all. I'm in the field in Bihar for the last 1.5 years, and we are trying to explore more on the flood aspects and how the healthcare at the primary level could be improved. So we just ask people during the post floods, like what do they do and how they manage their stress if it happens to them. So majority of the people, almost 99% of them were dependent on the family and the community support. So maybe my suggestions, if you would kindly consider, would be to strengthen the self-help interventions, if we could, as well as the peer support group, first thing. Second is, if the people need support, where do they go? So for the utilization of the services, telemedicine and other, we couldn't find much, but of course people seek care from the informal care providers. Almost 70% of them utilize those services. And in the cadre, in the cadre for on training teachers and other resource person, maybe informal providers, if it could be considered, because it's already like for the TB program and other, they are playing a good role. Thank you, sir.
ma'am. Yes, ma'am. Quickly, please, because tea is waiting for us.
Hi. So I'm Shahana Chakravarti from Action for Ability Development and Inclusion. We're called ADI, and we work for rights of people with disabilities. So one thing that is very important is that when we are training cadres, it's important that they're trained in how to respond to needs of people with disabilities. And one of the things that would be very important there is to train them in communication strategies, alternative and augmentative communication strategies, which can be used when you're talking to a person with disability and gauging the person's needs. So that is something that I wanted to emphasize on, because we realize that most of the people with disabilities during the COVID were just left by themselves. And the communication material that we create for everyone, so how to prevent COVID, that we felt needed some sort of adaptation, and it needed to be accessible in its format. So this is something that I wanted to emphasize on. Thank you.
Thanks.
Right, very many thanks to the panel. You brought us really close to the communities that go through all kinds of disasters, and for that we really thank you. Now could I request Rizvi sir to please offer mementos to the panelists.
And we will meet again at 11. Oh, there's very little time.
Yeah.
So you have to speed run to the tea and then speed run back. So you have 17 minutes for that. So you guys please run. We'll deliver the mementos.
Colleagues, really, if we can take 10 minutes, 10 minutes for tea, and be back, we'll get started with our group discussions.
Yeah,
Thank you very much.
11:55 we'll start, 11:55. Is that okay, Jyoti?
11:55, yes. Yeah. Thank you, sir.
Photograph. Dr. Manoharan. Dr. Manoharan. Photo. Come. Jyoti, you're not in any photograph. Come.
Thank you. Next time should be on a panel, you get coffee. And none of you opened it. What a tragedy.
If I am not in this place and there, I will eat all this.
Come.
You were so
So you have to approach the
Thank you for that point. It's very noted. I could really thank Thank you for coming. Please enter your tea. Look forward to seeing you back in the sessions. Thank you.
Yes. So, my part is communication. Obviously, ambiguity and silently. We can accept the risk. So nobody is highlighted the risk. Risk is given by the mental health. So mental health cannot be for any medicine or something like that. So the community based to activities that we are doing that.
Where are you? Which organization are you?
Yeah, I will give it my card. Basically, disaster is the core police official and everywhere. So it's strengthening what we are doing. The act, using the act. So disaster is everywhere. Disaster is everywhere. So I have to face with each and everything gently and so we are doing meetings. These are not focusing and like that and not like that. Yes. We are doing the pure humanitarian.
Very, very nice.
Thank you for coming all the way to. So not about that. I support the political. I don't think politics. That's it. The people who want to make the job or something. So it is really highlighted the importance of mental health. So especially I have to suggest to you. So this is very important. That's why
यही चीज दूसरों में बढ़ाती है ये कैंडी लाया तो इस बार मेरे क्यों बोल रहा है नीचे राउंड लगा इधर से एक बार बोल देना कि दिनों में बोल देंगे चॉकलेट में अपना चटनी भी चॉकलेट में अल्टरनेटिव में यदि लगा तो चॉकलेट वाली भी रखा रहा जो उसकी बची है ना सुन तो इधर से बता जल्दी नीचे भेजा उसमें ना जो मंगाने के लिए उसको दे रखे हैं उसको चॉकलेट की भी डिमांड दे देंगे बाथरूम नहीं लगेगा खाली रूम में लगेगा
Hi, Krishna Sapan. Good morning. Good morning. तो क्या सेशन था सुबह? फर्स्ट सेशन क्या था? basically it was an agricultural supply chain. So when we heard it is more about technology, materials and management practices.
Hi, Puneet. Puneet, hi. Can we have the presentation? All right. So, colleagues, you will be now in groups of around 10 to 15 each. We have volunteers who will be anchoring the groups. What we are going to do is have as structured a group discussion as possible. And we will also come really close to each other as you're forming the groups. We'll form around 5 groups of 10 to 15 each. Can I please request everyone to make sure that in your groups, there are people from academia, from CSOs, from SDMAs, and there is a mixture of people in every group. So if you know someone, move away from them and go towards people you don't know and form groups. Okay, so we can have group 1, 2, 3, 4, 5. See you, thank you. Sure. Done. Next week. Enjoy the long weekend. Yes. Right, so we can have group 1, 2, 3, 4, 5. Four, 5. That's all right. Let everyone have some space. So can we quickly form these groups in about 2 minutes, very quickly, efficiently, as we may mobilize at the time of emergency, very quickly. 1, 2, 3, 4, 5. Yeah. That's really all right. You can do that from that level. Also apologizing for how the chairs are laid out. It's not, I mean, feel free to move and shift your chairs around so you can look at each other. Just a quick reminder that we would like representation in every group from SDMAs, CSOs, academia, think tanks, UN agencies, if anybody is here. Mix around.
So can we start putting our hands up if your group has a diverse membership? In your group, do you have SDMAs? I can see friends sitting together. You all know each other? You have to move and sit with people you don't know. So you don't know them? Okay, great. So there are CSOs, SDMAs, excellent. Everyone mixing around? All right, yeah.
Yeah, all groups, please hello, all groups, please pay attention that in every group, we need at least one representative from the state. So from SDMA or CSO, so please make sure that every group has one representative from SDMAs.
All right, colleagues, are we sorted? Are we seated? Yeah. Group 1, 2, 3, 4, 5. Fifth is still forming. All right, colleagues. So, Shishi, may I also? So, colleagues, are we all settled? So I'm going to get started with this. We will, between me and Shishir, we will speak in English and Hindi. So, okay, so we'll get started now. We had initially planned this for 2 hours because we're running late. We're going to do it in 1 hour so everyone can get to lunch on time. Yeah, and maybe that's a good thing because if we have too much time to think, then we're going to possibly get nowhere. So very quickly, this is the scenario for all of you. If we can have everyone's attention, please.
You will speak it up, Jyoti.
Let them settle. You can just go and ask. Okay, so this is a really simple scenario. It is on both the screens, so everyone can see. During a recent flood, a child who had lost her family was brought to a health clinic, right? The doctors treated her physical injuries, but they did not know how to take care of the emotional trauma. A school nearby was trying to support all of the children in the community, but the teachers were not equipped with trauma-informed care. There is a local child protection officer who's in the middle of this disaster, who wants to help all children who may be separated from their families, like this one. But then the child protection officer is not aware of this case or this girl who's sitting in the health clinic. Right? 5 weeks passed before the child received proper psychosocial care. By then, the child had stopped speaking, she wouldn't eat, and had sleep issues. Eventually, 5 weeks later, a community volunteer eventually connected the services. Yeah, so largely here we are speaking about health, education, and protection services. Please don't limit yourselves, because of course there are more, but specifically because we have also limited time, it'll be really good to focus on these 3 sectors. And what are some coordination? Because definitely it shouldn't take 5 weeks for such a thing to happen, right? Eventually the child was reunited with relatives and returned to school. But the question we're all faced is, could this have happened sooner? And so we have 4 questions, which we will take around 5 to 7 minutes to discuss each, and we're going to keep time. Yeah? So really kind of, you have your charts, please write down and discuss. We will have more time for discussions as we go, but we really want your very targeted inputs on these questions. Yeah, is the scenario okay, Shishir?
Yeah, please ask them if they wanted to.
Would some of you like to hear this in Hindi as well for clarity, or is this okay? Okay? Everyone's okay? Okay.
So, जो सिनेरियो है वो ये है कि एक रिसेंट बाढ़ में, फ्लड में एक चाइल्ड, एक बालक समझ लीजिए, उसने अपनी फैमिली को लूज़ कर दिया है, वो बह गए हैं और उसको एक हेल्थ क्लिनिक पे लाया गया है। हेल्थ क्लिनिक में उसकी जितनी भी फिजिकल इंजरीज़ हैं, जो बॉडीली इंजरीज़ हैं, वो तो ट्रीट हो गई हैं, लेकिन किसी तरह का कोई इमोशनल सपोर्ट या किसी तरह का उसे कोई काउंसलिंग नहीं हुआ है। एक पास में स्कूल है जो बच्चों को सपोर्ट करते हैं ऐसे आपदाओं में, लेकिन टीचर्स को भी ये नहीं पता है कि बच्चों को इस ऐसी परिस्थिति में काउंसिल कैसे करना है, बच्चों को कैसे टैकल करना है। एक लोकल चाइल्ड प्रोटेक्शन ऑफिसर भी हैं, लेकिन उनको भी जो मेंटल ट्रॉमा है या जो बच्चा इस समय मेंटल ट्रॉमा से गुजर रहा है उसके बारे में आइडिया नहीं है कि क्या करना है। 5 हफ्ते बीत गए हैं और उस बच्चे को प्रॉपर साइकोसोशल केयर नहीं मिली है। वो किसी से बात नहीं कर रहा है, खाता नहीं है और ना ही ढंग से सो पा रहा है, जो कि एक समझ है कि उसको जो ट्रॉमा हुआ है उसकी वजह से हो रहा है। सो एक कम्युनिटी वॉलंटियर इवेंचुअली आगे आते हैं और हेल्प करते हैं, लेकिन उस चाइल्ड को रीयूनाइट करने के बाद भी उसके रिश्तेदारों से और जो उसकी नियर फैमिली है और उसे भेजने के बाद हमारा प्रश्न ये है, क्या ये सब चीज़ें पहले हो सकती थी? अगर इन चीज़ों पे पहले ध्यान दिया जाता कि उस चाइल्ड को एक साइकोसोशल काउंसलिंग और सपोर्ट की ज़रूरत है, तो बहुत सारी चीज़ें टल सकती थी। तो जो हमारे अगले 4 प्रश्न हैं आपसे, वो उन्हीं को लेकर हैं कि आपको उन चारों प्रश्न को देखना है और आपको आपस में विचार विमर्श करके उसके आंसर्स बनाने हैं, जवाब बनाने हैं कि एज अ वॉलंटियर या एज अ साइकोसोशल सपोर्ट आप क्या कर सकते थे।
Yeah, perfect. So the first question we have is really around roles and responsibilities for mental health and psychosocial support across sectors. Yeah. So in times of crisis, as we saw with this child, there is a health facility involved. There is a child protection officer that's going around not knowing that there is such a child requiring services in a health facility. And there are teachers nearby who want to support, but they're not able to contain the trauma, okay? So in times of crisis, health, education, and protection services play really critical roles in rehabilitating and supporting the mental health and psychosocial well-being. What are the specific responsibilities of each sector in responding to these needs?
We've given you the idea of a child, but please think about people with disabilities, the elderly, women. Yeah, so essentially think of all, but then we are just giving this example so that we are able to be targeted in coordinating these three essential services. What has worked in your experience, because we have people from the states who have dealt with diverse disasters. In your experience, what are things that have worked, right? What are some mechanisms that we can put in place that you would highly recommend, whether those are existing or not? Yeah, so we can maybe take 7 minutes to just jot down points. No right or wrong answers, okay? We're just going to negotiate everything. Okay.
So पहला प्रश्न ये है कि जब भी कोई आपदा आती है तो हेल्थ एजुकेशन और प्रोटेक्शन जो सर्विसेज हैं उनका बहुत महत्वपूर्ण रोल रहता है. सो आपको ये बताना है कि ये हेल्थ एजुकेशन और प्रोटेक्शन सर्विसेज की जो हम बात कर रहे हैं इसमें हर सेक्टर का स्पेसिफिक रिस्पॉन्सिबिलिटीज, उनकी आवश्यक जो जिम्मेदारियां हैं वो क्या होनी चाहिए और क्या हम कर सकते हैं कि ये तीनों सेक्टर ये आपस में मिल के काम कर सकें और बहुत इफेक्टिव रूप से जो साइकोसोशल से संबंधित चीज़ें हैं उसमें सपोर्ट कर सकें. इसमें कोई सही या गलत जवाब नहीं है, आपको अपने केवल विचार रखने हैं और आपको बताना है कि क्या आपको सही लगता है कि ऐसा हो सकता है.
think what we came up as a group is if we focus on the larger picture, then these smaller ones can be coordinated better over time. So
Okay.
looking at that picture first.
Okay, great, thank you. Anybody has anything to add? Yes, ma'am, please. We can't hear you, ma'am.
Yes, sir.
Yes.
I'm Professor Pooja Anand. I teach psychology at Daulat Ram College, University of Delhi. So we actually became a subgroup at the time of discussion, and the main idea that we were looking into was that yes, we are breaking down a lot when we are talking about solutions. We could also see the question said health, education, this, that, and the other. So instead of breaking down, I understand, I mean, at the implementation level, it does work. But at the understanding level, at the conceptualization level, I think everything should be brought together. And if particularly we are looking for solutions, then I think a very key role, because I'm from education, so I think sensitization is very important. Community engagement is very important. And I was just discussing with Sir over tea that why not involve right from the start, educating our teachers, our students, right from junior school, middle school, and of course the college students. They are so eager and willing to learn. So to train them into providing psychological first aid, not just the psychology students, but all of us. So implementation is very important. Integration is very important. So we are talking about coordination. So all these points we were discussing. So I hope that is something that makes sense.
Thank you.
Thank you.
Group 4, you're from the same group?
Little differently, sir.
Oh, so that's the split group. Yes, please carry on. Yeah.
Yeah, sir.
Group
So,
opposition. 3 opposition. 4, acha.
so, so my name is Dr. Sabir. I am a psychiatrist. I'm from Manipur. So, the discussion of intersectoral coordination and other things are there. But in this particular case, I want to point a little bit of step-by-step things that could have been done. For example, the doctor, in this case, the doctor treated the patient, saw the patient, saw the child, and he looked for only the physical symptoms. So what could have been done is he could have looked for some psychological symptoms, may or may not be present there, but he had to look there. So in that looking part, now the next thing, the teachers are also there. Teachers are unable to help because they are not able to know, they don't know where to look or they don't know what to look for. So there again comes the training of, the training of the teachers to look for distress in the child. Okay, if there is in this child, now there are 2 things. To anticipate adverse outcomes in this particular child, losing of the parents. Of course, the other factors can be age, gender, the disabilities. Suppose if the child is disabled, then we can anticipate there are adverse psychological outcomes can be there. The next thing was, the next thing that could have been done is to continue talking to the child. So ultimately, I don't know whether it was done or not, but the talking and the interacting part with the child was not there. So listening part was again lacking here.
I'm sorry,
So-
Doctor, just in the interest of time, we've got maybe 5 minutes or less.
Yeah.
We want to discuss challenges in
So
coordination.
I'll just come to that. I'll come to that.
Can we just get to it quicker? Thanks.
Yes. So yeah, the coordination part is once I think here we can involve the media. We can involve a particular nodal kind of a thing, and only that group or that nodal officer will be able to link in a particular situation. So that can be done, I think.
Excellent. So we'll be getting we've got all these responses, we'll be getting them. We'll be pulling out all the important points that are made. But whichever are the most important in these 4 questions which your group has collated, please mention them now. What we are doing is that we are going to finish this session at 13:15 so that we can feed our hungry stomachs. And then at 1400 we'll come back. 1400 to 1430 we will get back to this discussion and generic feedback about any points that you wish to make which you may have left out earlier during the workshop. And 14:30 to 15:30 we will have 1 hour of the financing session. 15:30 to 16:30 is the closing session. So every group will get a chance to speak, and otherwise also if you wish to say anything. So thank you for that. Does this group anything to say?
Hello, sir.
Yeah.
Sir, I just want to add a new point apart from what everyone else has discussed. So,
Where are you? Hiding. Oh, okay, hiding behind. Okay. We are not able to see. Okay.
So my name is Annie Yangfo. I am a disaster manager at the district level from Arunachal Pradesh.
Great.
So working in the field, what I have faced is that I was posted in a particular district called Upper Subansiri for 3 years. And there, sir, like yesterday also we have all discussed that the entire topic of disaster and even mental health is so new. Right now it's going on, it's speaking up. So the thing is that at the district level, we don't even have a psychiatrist or even a counselor. So that is a far-fetched dream. The other things, so we can just think about it at like a later stage. So what I realized is that at the district level, we have volunteers, Abda Mitras, and community volunteers who are trained to handle your people post-disaster, during, and even during the pre-disaster. So like what the CMO of NDRF today had mentioned, that we give a lot of trainings when it comes to how to prepare yourself for disaster during pre and post disaster, but issue of mental health has not been introduced yet. So if we can train these volunteers how to deal with the victims of disasters in terms of mental health, I think that will be very helpful. And apart from that, yesterday we had talked about the ASHA workers, people who work at the ground level. I just want to mention another group of people who are really very important, especially in our state. They are the workers from the Rural Livelihood Mission. So they work very closely with the self-help groups, especially the women. So if we are able to train them how to deal with psychosocial support. So I think they can empower the mothers in the family who are the head of a family unit, how to deal with mental health and psychosocial support. So I think this is how we can make the last mile, connectivity when it comes to disaster and trauma response. Thank you.
Sir, hello. Yes, sir. Sir, we have a group discussion actually through brainstorming. I have just few points. I will take just 2 minutes. So as per the problem statement, after 5 weeks, proper help has been given. So we have identified some points. Point number 1, risk assessment and early identification through district mental health program in the camp. Then ASHA workers should be trained to give psychological support. Basic need of safety to be identified. Real-time data to be tracked. As we are just purchasing something from Amazon or Flipkart, we get real-time data. So like in this case, 5 weeks has gone, and there is no help to that person. Then specific responsibility should be defined. There should be one escalation matrix. So if there is failure in one level, it can go to the next level. And then most important thing, like in the private industry, we have key performance indicator. But in mainly government sector, we have missed those key performance indicators. So key performance indicator can be defined and tracked. So all these points we have. Thank you.
Okay, anything left? Yes.
Good afternoon, everyone. I'm Atisha Sood from NIDM. Sir, in our discussions, we have discussed regarding challenges of communication. We have proposed regular meetings of multi-stakeholders even before the disaster so that different departments know each other. And in the time of disaster and response, they are familiar with each other. So these meetings can be done. They can be done virtually so that nobody has to come in person for the meeting as such. We can have teleconsultations to ensure long-term psychosocial support when the troops actually, move back. And we can also have buddy system in place to ensure that psychosocial help is provided to different people in order to ensure the psychosocial health of kids. We can have continued education as part of a priority by using infrastructure from different religious groups maybe, and that will help them. And there is also district health society in place who have regular meetings in some districts of the states that they are mandated to have meetings from time to time. So those meetings can also be used as one of the places to help identify different resources for providing psychosocial first aid after disasters for different groups. That's it from my side.
Thank you, thank you. That group at the back, the SDMAs.
Very good afternoon, sir.
The silent
Sir,
bottom of the backbenchers.
sir, I'm here, sir.
Yes, please.
Sir, I have focused, we have focused right from the grassroots level, sir. So right from the village level. I am trying to emphasize, what should have been done in the right way. Because in the scenario which has been, there has been a failure on the part of the system to impart the mental health and the psychosocial support to the child, and it was too long, after 5 weeks. So right from the grassroots level, there is Gram Sabha in the village. So the panchayat should be, it should be taken into a regular curriculum, that what are the likelihood of disasters that can occur in that particular zone. There are some unprecedented and some are which are seasonal, jo hota hi rehta hai. So these are the kind of disasters that occur. There should be places identified in the villages, and every villager should know where to go at such time of disasters. There should be a mechanism of 5S, what we say, sort, put in order. So every villager should know what to take and what not to take in such occasions, in such events, what to be rescued and what not to be rescued, so that they can remain alive and leave a particular secure position. Because right from the word go, that mental health issue comes into picture, because those who get rescued and those who could not get rescued. So those who could not get rescued will have that problem because they did not know where to go. So right from the grassroots level, this has to occur. And thereafter, once this particular thing is sorted out, all the persons at the village level, we can have volunteers, what we call the Apda Mitra, teachers, local teachers, even the Gram Panchayat members. They should all be sensitized for mental health and psychosocial support. Basic knowledge should be there with them. And every monthly, they should keep on having this particular repetitions during their Gram Sabha meetings. So villagers would be knowing what to do in such situations, first of all. Thereafter, the doctor's chaos was there. Now, in such a scenario, when the doctor is there, doctor should know the mental health problems and how to support them. But doctor would not be in a position to give that particular mental health support in such particular times of crisis. So what they can do, they can have mock drills for particular disasters, and they can have minutized these particular and how did they respond, so that the whole team is accustomed to take care of such particular disasters. So very frequently occurring disasters like flood is there, cyclones are there. How did they manage in such situations? So there should be mock drills and minutized, and take lessons from where did they lack, with some third person overlooking all the particular events. Everything should be documented. Once this particular thing is done, then this particular segregate this data, in this case, a child is there. Now, doctor would have treated the child, if the child is treated injured or whatever, he would have segregated the child, if there is a protocol in their particular system, to a particular area, that all children who will be coming with injuries would be kept in this area. All women, a particular area. If the women is with their children, they can kept in same area, pregnant women. So they are segregated, and there should be another person along with the support of the doctor who will take, you can be a multi-purpose health worker or the female health worker or a counselor in the PHC, who will take the full data, and this data is kept there. And after that, respective teachers are there, or the Abda Mitra is there. Whoever person is capable enough to give that mental health, first of all, identify the mental health problem, and then provide the mental health support. Even when the crisis is over, say that like the third question is that the funding is gone and the crisis, everything is almost coming into places. At such times, these data can be segregated with other NGOs and whatever, like, we have to make guidelines for that, who can come into picture, medical colleges, psychiatrists, pool of psychiatrists, counselors, so that the long-term particular mental health problems are taken care of. Thank you, sir.
Thank you. Thank you. So we also have a little bit of good news that lunch is pushed back by 10 minutes because...
So we have to keep you engaged for next 10 to 15 minutes.
The rotis are still being made.
You are the part of that Sarkari group?
I am, but I wanted to share a personal
Ji, ma'am,
observation,
please.
if that's okay. I'll not take long in interest of time, although now that we know that it's extended. My name is Soumya. I'm a psychologist, and I've had very limited experience of working with ministries and department. So somewhere my position is a little privileged. I get an outsider perspective into things, but I think that's also helping me to observe a few things over here. I'm hearing a lot of points which I think a lot of us know already, but I suppose the problem is in the consolidation and integration of these strategies. To my notice, what I'm understanding, and like for others to also correct me here or share to what I'm sharing right now, is that the problem is in us assigning our own meaning to what psychosocial support is and still looking at it as a very isolated process. Like right from the beginning, I'm hearing that, okay, you know, a medical protection officer, child protection officer, medical professional will be tending to a lot of things out of burden, out of responsibility, but then they can later on triage and, you know, send the child or the person who's affected to the desired services, right? Why is the psychosocial aspect being left out or seen as a separate process? Why can't the person who's the first responder be primed with the kind of questions that helps them to triage then and there and then send out, right? For example, if a child who has been affected comes to the first responder and is stating whatever concerns they are afflicted with, the person could, in the beginning state, ask, is there something that you've been doing to keep yourself safe so far, right? Now that gives us an information whether the child needs medical or mental or emotional care at that point of stage. It's possible that the child may say that, okay, I have certain physical grievances, and the doctor steps in at that point of time, right? But the first responder could also help the child know that these are some of the things that are also on the site, if required, right? And I know I'm using a very vulnerable example over here of a child. It could very well be attributed to an adult as well, to
Okay,
an
Soumya, we
elderly
got
as
that.
well.
Thank you. Thank you very much. Nicely. Now, 5 groups. Different ideas, different views. And the typical view is from the last group, is the government approach, the Sarkari approach. You should have done, ye karna chahiye, wo karna chahiye. That is what how India works. ठीक है ना? When postmortem things happened, when the question was simple, during the recent flood, the child who had lost family brought to a health clinic. He was just asking you what all things you can do it and how to do it. We are not asking कि ये हो जाता, वो कर देते, community में करना था, नहीं कर. That is the remedy, that is the things we are asking for the future. But suddenly that scenario has come, कि one flood, one incident, this thing, the question should have been answered the simple way. But first of all, that it was good, all 5 groups They worked, they responded, and their answers was absolutely good. I visited almost all groups, and Jyoti said ki all answer are matching. Only thing is somebody is putting the last point is the first, and first point is the in middle, and middle point is the last. But although everybody has reached to the same conclusion ki what need to be done. And when Soumya met me outside, and this is the first time I found that so many psychologists are there. So I asked Soumya, Soumya, can you read my psychology? How is that? What type of person I am? And I said, that I can't do it. That is a Jyoti sitting inside and other people are sitting there. You go and connect with them and they will be able to tell you what is your psychology. So I will take one session with Jyoti ji. But now, one group which I was attached here, the second group, and this is the one group where is dominated by ladies. And all the ladies together, and one guy from SDMA who is a senior person who do such type of thing day out and day night, you can say that. Every day he is meeting such type of accidents or events, is meeting them. Nobody was listening. He was shouting. वो कुर्सी के ऊपर खड़े होने वाले थे क्या सुनो सही मेरी बात कि मैं डिस्ट्रिक्ट से आ रखा हूँ, मैं अरुणाचल से आ रखा हूँ, मैंने ये त्रासदी मैंने झेली है, देखी है, मैं रोज देख रहा हूँ. देखिए माशाल्लाह की क्या बात है, उसकी कोई बात सुनने को तैयार है.
हमने बनाई थी स्ट्रैटेजी की सबकी लेंगे, बिल्कुल सबके लिए थे, और the idea of group process was to get multiple viewpoints.
आपने मैम किसी के लिए ली, आपने सिर्फ कोई 2-4 ली.
नहीं, मैंने क्या किया, मैंने एक और महिला का सहारा लिया, इनके थ्रू अप्रोच किया.
But that was good, man. Good, it was good. But what I like this group is that they have drawn the 3 circles. And the middle circle, the circle 1, 2, 3, and the one circle in between, they were able to nail down what exactly is requirement. And that is the best thing in disaster management has happened. Man was there or not there, but this shows the Mahila Sasakti leadership. That is what we wanted to see, and they have proved that yes, they can do it. तीनों जगह इकट्ठे हैं. You take it from girl from Maharashtra SDMA, she spoke very well, the girl. But the last group is a typical SDMA group. हम ये भी करना चाहिए तो भी करना चाहिए. अरे बाबा 5 साल का बच्चा है, खोया है, उसके लिए क्या करना चाहिए, क्या नहीं करना चाहिए, वो कीजिए बात. ठीक है? Okay. So now we will give you the gist of thing कि what all things you people have recommended. We will take the feedback from all the 5 groups, and then we will all the scenario, the 5 or 4, what is the exercise was given to you, we will put it in the paper form, and all that we'll take out the booklet and we will form it into a proper SOP sort of thing, and it will be shared with each and everybody so that in future, if such type of things happen, it is mandatory for everybody to what to do, what not to do. And it is a simple thing that training and awareness. That yesterday, when the Joint Secretary from Health came, and he said, one thing he said very clearly, that the coordinations and communications, they are the 2 main astra we should have. First is coordinate and the communication. And that awareness of that area is a very, very important. When we are developing this Abda Mitra scheme, it is 784 districts are there in India. We can't develop this Abda Mitra for each and every district. So we have worked out which are the 4 major disasters in India, hazards are there. That we thought it is flood, it's cyclone, it is earthquake and landslide. So we have selected 350 districts. And 350 districts, we have made this Abda Mitra, 1 lakh volunteers. Out of that, around 20,000 are women participant in this Abda Sakhi. We call them Abda Sakhi. Now we are taking up Yuva Abda Mitra scheme where NSS, NYKS, NCC and Bharat Scout and Guides are there. We are making 250,000 youngsters as a Yuva Abda Mitra in all these 350 districts. So it means that we are reaching out to the community level. But what this Abda Mitra will do? That is a big question mark. They have been given a 14 days training, they have been given a kit, they have been given a 5-year insurance, they are getting a job opportunities. Now to train this Yuva Abda Mitra, we have selected, out of 1 lakh volunteers, we have selected 1,300 or 1,400 volunteers who are the best in the lot and making them master trainer in NDRF Academy or in Fire Academy, and they have been provided with the master trainer certificate. Now these people, we are going to train our 250,000 volunteers in all 350 districts. Why I am saying this is, now this is the job of, this is a work of SDMA at the district level and SDMA level, how to use these volunteers. If you go to South Africa, they got only 600 volunteers. And the 600 volunteers, they visit in a month. They visit 42 to 43 families. Each volunteer has been assigned. You will visit 43 families or 42 families in a month. And he will go and he will just give them a talk for 10 to 50 minutes for forest fire, heat wave, flood, and other things. And now he says, lunch is ready. So these people, these 600 volunteers, in a month, they visit 26,400 families. In a year, they cover around 3,12,000 families in a year. This is the job of volunteers, they do it. If this is the same thing, we can do it in India. Just imagine, 50,000 volunteers, considering India, culture, going on duties, not doing, this is not my job. I've been trained, my training is only for me and my family. If these Abda Mitra can be motivated and they can go to all the families in their area, they can train them, they can give them, and this is in the future what we are thinking, include them into a, what we call psychosocial network. We want to train them so that at the village level, at the family level, some participants, some volunteers are available. Otherwise, how long you are going to train Anganwadi workers, Asha workers? They are also tired. They are doing so many other jobs. The people are here. They are doing so many jobs. And give them another job with the minimum pay they are getting. They'll say, what all things you want me to do? I'm looking after their primary health centers. I'm doing this. Other things are also they are doing, which is not to be mentioned here. So many work they are doing it. On top of that, you are giving them this is the community, they have to come forward. The community volunteerism has to come forward and say, yes, we are volunteering ourselves for this cause. Because psychosocial work is one thing, it will come once in a, it is not everyday things. One major thing will happen, that is the only thing it will come. Now cyclone yesterday, I was mentioning somewhere, in 1999, when 13,000 people we lost in Paradeep cyclone. And today, when Biparjoy, Ramel, Amphan, and the mortality rate has come down to 0. So there's no need of psychosocial things. This is how the community has to be developed. So you have to find some work. When you go to bank always asks you KYC, know your client. When they are asking you Aadhaar card, कहाँ रहते हो, क्या रहते हो, father का नाम क्या है, mother क्या है, धर्म क्या है, जात क्या है, everything they ask about you. For only they open the bank account. So we have to generate a team of such volunteers who know your communities. Until unless you don't know your community, you cannot participate, you cannot become a psychosocial expert in the group. If the group we can pick up from these youngsters and train them little bit, and they know in my village how many old people, how many ladies, how many pregnant ladies, how many other thing, disabled person, how many children are there, then they can start working on those things. So we will continue and we'll meet after 2 o'clock because that lunch is ready and we don't want you people to get ready for the lunch.
So please come back by 2:05, 2:10 and then we'll have a 10-15 minute thing and 2:30 we'll start the finance session.
Thank you.
solutions. And then we go into a panel on financing models for MHPSS and disasters. And then we close for, we have the closing session and then tea. Yeah, so because we're running late, we're just pushing the refreshments to 4:30. Hope that'll be okay.
So refreshments will be after the closing session, and they'll be right here. As an incentive to attend the closing session, and the closing session is an incentive to having the tea. So welcome back to whoever has come back, and the others who will have not, we will welcome them again a little later. So are there any points left? Anybody who wishes to give us some important feedback from their SDMA, officially from their SDMA or their state, or officially from their organization? हेलो हेलो नहीं चल रहा है हाँ फिर वो बहुत तेज कर देंगे हेलो हेलो इसमें तो और है ही नहीं कुछ Can you hear me at the back? Okay. So you want to say something? Please.
Yeah. Thank you, sir. I will speak in.
Sir, ये feedback session है. आपको इसी में आना है. अच्छा, sir doesn't want to listen to feedback. Yes,
Yeah.
ma'am.
I want to say something, but I will speak in Hindi also.
जी जी बोलिए.
Yeah. I am Dr. K. Prajapati from Gandhinagar Civil Hospital. I am psychiatrist. मैं ये कहना चाहूँगी कि that point is covered, but बच्चों के भी training program होने चाहिए pre-disaster, so that child can self-help, child can be prepared for these disasters, and how child can self-help and be prepared.
Thank you, ma'am.
બેન તમે ગુજરાતીમાં કહી શકો છો.
So any other issue somebody has here? So I would like to address one question to all of you, that this point keeps up about training. Everybody says हमें training चाहिए. अब government of India कितनी training करेगी? So it is the reason why SDMAs and DDMAs were created was so that not that they can do the training, but they can incubate the concept of training. There are so many non-profits, there are so many other ministries also in every state. So getting them together and doing training, even a school does training. So orient the school and the school will do your training for you. Like the health ministry officials were telling us yesterday that they trained 2,200 counselors. But the biggest possible A-class thing they got in their hand was the 11 lakh teachers who they were able to orient. So training of 21 days versus orienting for 5 days is good enough. 5 days for earthquake preparedness, 5 days for fire safety, all in one, and within those 5 days teaching about PFA is a very easy thing to do. So please don't look at NDMA to do the training. If we do the training, we are doing it to do training of trainers. And we can definitely do it here, do it there, but it's not going to have an outreach. One thing that you can reach out to non-profits with is that, you see, in government we have big issues with regard to tenders and all that. So it's difficult to reach and finally get an agency that can do a nice little video for you, which in itself is a training module. So like we deliver lectures at various places. Suppose we convert that lecture into a PowerPoint presentation with a small inset of your face, and you do 30 minutes of that lecture, you put it on YouTube. So imagine the reach of the same content, the same human being, and the same rank and the same designation or whatever. But rarely does anybody do it. It's only those life counselors that go to schools and others, उनके पास ऐसा होता है. तो ये चीज़ बहुत आसान है करना. You can do it with ready-made platforms that are available. We've tried to push it in government, but at the end of the day, you know, I've somehow this is one of my biggest failures in life, that I've not been able to create a training video for myself also. Even though I know that if you go to the iPad, there is a way in which you can do it. Still, I've not done it. And this is the best way of training. Put it on YouTube. If NDMA or SDMA's YouTube channel starts hosting these training videos, then all you need to do is, if anybody asks you training, please look at so-and-so video. Here is the link. तो ये चीज़ आप लोग सब कर सकते हैं. Those young ladies from DR college were asking what can we do. These kids can create those videos and then put them out. हम लोग क्या question आता है? हाँ? Yeah. I've completed. Yeah.
So I thought it's just a best time to do product placement. But we have a lot of videos, sir, already. And I just wanted to place it here because a lot of stakeholders are already here. We means, okay, I'm Charul from Protsahan India Foundation. We have made videos in Hindi, on PFA, in English, and 17 more languages are underway. These are very small, 3 to 5 minutes videos. So as far as training is concerned and the video learning is material is concerned, that's been happening. We are
Please name your
Protsahan India Foundation.
Please remember, Protsahan India Foundation has lots of 3 to 5 minute videos on PFA. So please look at them. It's freely available on YouTube. So please look at them, and if you wish to use it, use it. Yes, ma'am. Please carry on.
Yeah, I was just placing it there so that it doesn't get
So your automatic
dissolved.
placement has worked. It's been placed.
Great, amazing, but yes, we
so
had...
we encourage anybody who wishes to put out such a these are common goods. So if that non-profit has created a common good, so we are very happy to push it out. Like in the next session, we'll show you a discussion from a non-profit of what they have done and why we are so happy, and we want to create a common good out of it. That if a non-profit can do a thing like this, why can't every other non-profit do it? It's so easy and doable.
However, I would also like to draw attention towards just one thing that because we've been hearing a lot of conversations around training the systems that are already there. If 10 different entities go to train the same system and people in that system, I would talk about Anganwadis here. We've been talking about ICDS system a lot, also because they have a largest network. But here is the thing, if 10 different entities go there and try to train the same system so that they can do things, then there is a lot of burden and fatigue. I think when we were talking about pool, yes, so two things, and even when we go there, of course, they would want, like there is a limited time that they are already performing the task and jobs that they have been given. I would also like to place it here that our existing people in Anganwadis, ASHA, ANMs, and other entities have that kind of capabilities. The only placeholder here is to be able to reach them and to be able to not create the kind of fatigue because they are already taking care of 10 different things. That is where the challenge comes. Plus yes, there are like coordination की हमारी बहुत सारी बातें already हो चुकी है. मैं वापस से उसको repeat नहीं करना चाहूँगी.
Does the health ministry have any such training videos? Anybody knows of that? Yes, sir.
I wanted to bring our discussion back to where we ended last evening. Krishna ji was trying to nudge us that create a system for delivering MHPSS services during emergencies. And he was asking the health sector, can you do it? So last couple of years ago, during the Chennai floods, we came across this system in Tamil Nadu, which I thought was very good. So they have one mobile unit per block. So 400 blocks are there in Tamil Nadu. So they have systematized delivery of mobile units there. So mobile unit includes health services, environmental health, and also some nutrition services. So 3 sectors are already converging there. So can we not build little bit of more input on MHPSS, or maybe add on one more person there on such mobile units, So then mobile units become very important during emergencies, during disasters, because and
That's a good point.
yeah, and Tamil Nadu was able to bring in a lot of district level mobile units into Tambaram city where a lot of flooding happened. And we could sort of really do a great job, government could do a great job on health and environmental health particularly.
Great, thank you. So is there any important thing left which you are dying to, yeah, please do.
So good afternoon, everyone. I'm Naveen Shukla, representing Save the Children India. So largely, basically, if we talk about the child-centric, so we have developed a comprehensive module on MHPSS with the support of National Institute of Disaster Management, a wing called CCDRR, Child-Centric Disaster Risk Reduction Wing, which is based in Vijayawada. And we have, as of now, we have already trained more than 1,000 government officials. So that module can be adopted. So where we can train the first responder. Second, some of our panelists has highlighted the child-friendly spaces, which has been integrated into the shelter homes. So under these CFS, this can be proposed to train, especially who is the anchoring of this CFS. So that can also be possible where Save the Children can anchor and support that.
Thank you.
Thank you, sir.
Anybody else? Yes, please, sorry.
Good afternoon, sir. This is Danish Aziz from UNICEF. I work as the education specialist and leading the school safety and mental health piece for the education section. Now, I've been following the discussion since yesterday. One of the things that I was seeing that we haven't had enough discussions around, the role of education, role of teachers. So I'm very glad to see in the group discussions there were some, areas where it was taken up. Also, I think why it's relevant is from a MHPSS point of view, because under the school health and wellness program also, teachers are being trained under, one of the modules is MHPSS, and also separately they have been, some of the states have been doing training especially on different aspects as well. Not going to say on because teachers are already, as they keep saying, they are overburdened with different responsibilities, but naturally during emergencies, during disasters, they are, as members of the community, also first responders, and they're also a cohort of people who are very respected, accepted by communities. So they could play a very vital role. Can we also look into how we can engage them? That convergence, if it is had maybe at the local level, and I feel maybe at the local level that convergence is much better, rather than at a higher level where line ministries or line departments are not really speaking to each other on these issues when it comes to mental health or emergencies and disaster. Education department, we had with Sarabjit sir in 2018, for example, in Jammu and Kashmir, held a child center emergency preparedness workshop. It was like a very comprehensive workshop. The different departments had come together. That was an instance, and we exhorted the education department to prepare a plan for themselves. So I think this is just to put a point across that the role of education department also, it has a very important role. Teachers can also be, because they are embedded within the community, and not just play a very important role as first responders, but also, tackle issues of mental health in emergencies very well, because they are the ones who are working with, specifically for children, because they are working with children on a day-to-day basis, and they're also very well connected to parents, community members as part of maybe school management committees, village education committees as well. So that's the point to raise. How can we enhance the convergence with education? Thank you, sir.
Thank you. So those are lots of points. So in the final thing that when I speak 5 minutes at the closing session, I will mention education, I will mention childcare, mobile units, YouTube videos for training, I will mention about the livestock. I'm going backwards, so maybe then the big point that Jyoti mentioned about do no harm, and then what was mentioned by Dr. Jay and many others yesterday, that debriefing in itself is re-traumatizing. That I think for me was a very big takeaway, that debriefing is re-traumatizing. Just one sentence says so much. Then respectful treatment was an excellent point. I spoke to a lot of people about respectful treatment, so I wanted to identify where is the problem coming from. So the problem, is it coming from the uniformed forces, army, navy, not navy, army, police, home guards, civil defense, medical personnel, teachers, civil administration, medical personnel. So most people are saying that if at all you get rough treatment, you get it from medical personnel, primarily because they're themselves under serious stress, because there's such a huge horde of people. They have a shortage of medicines. They don't have an answer to every question, and so a lot of irritation comes out. So we'll discuss this with the Ministry of Health. It's a very important point. Then what Kerala told us about how to use the media and how to kind of organize something and learn from Japan, that would be a very good point. Then that field operations manual that we are looking at Dr. Manoharan for, and you're stuck now, you can't walk out of that one. And then coordination was something that every one of those 5 groups was very worked up about. Then introducing MHPSS PFA in BPRND's manuals, which is already being done. NDRF, we will request the DG NDRF to include that in their BFRC. Resource mapping bulletin board, which Nimhans is doing, we will also offer our support. And there was one SDMA, Bihar SDMA was telling me at lunchtime that they have built already an IDRN equivalent in Bihar with 6,000 pieces of equipment which are already archived, which is a very good thing for them to do so, and to counter what the DR student was saying. Then resource mapping ho gaya. Access to guidelines, everybody was talking about reducing the size of guidelines, sir. You know what you and I have to do. And guidelines, अगर आप 100 पेज की बनाना चाहते हैं तो ज़रूर बनाइए, लेकिन उसका 2 पेज का एक pamphlet ज़रूर बना दीजिए, ताकि otherwise there's no point. And then yesterday we heard that Nimans has some 20, 30, 40 things on psychosocial, and Health Ministry has 4, 5, 6. We have 7. So who's going to read what? So what is the district magistrate going to do? Dr. Manoharan will tell us. Then what else were the points? That point I found very important, the one about whenever there's a disaster, already some 250 NGOs landed up at Wayanad, and you may have needed them on hour 0, day 1, but they may have landed up from day 2 onwards. So maybe a way of segregating कि आप first day पे आइए, आप second day, third day, whatever, some kind of a local system needs to be thought about. I know it's going to be very difficult to work on this, but we will figure something out over there. Teachers are great ambassadors. This is a very, very important point. The number 2,000 counselors that Ministry of Health was able to train, and 11 lakh are the teachers. So just orienting the teachers on school safety, fire drills, earthquake drills, and PFA for MHPSS is something which is a done deal, which we have to focus on. Then I found that art point to be very interesting. Art and that boy who went back to his village, he was a mute boy, and he took photographs of a clock with a plate of rice. And there were 2 photographs. The difference between the 2 photographs was there was 14 hours difference. So he was giving you a message that we get food 14 hours after the first meal in the relief camp we are in. So, I mean, what a way of expression, and it is so poignant also and so sad. However, they were able to make a change because of that. So how art can convey a message and how it can de-stress was a superb learning for us from there. And Dr. Vatsa has come. He already knows these points, so I don't know what to say beyond that. Dr. Vatsa, everybody knows him, no? Yeah? Sir, everybody is nodding, they know you. So Dr. Vatsa is our, for Mr. Rajinder Singh and myself, he is our teacher, our guide, our Guruji, and every morning we go and pay our respects So we're just recounting what are the important things that were mentioned. Not re-traumatizing, debriefing worsens the situation. Trauma voyeurs was a good term which I shall use in every future presentation. Mr. Garg had mentioned one thing yesterday, that hazard map can be made looking at the areas that are already at risk. So if you have flood risk, landslide risk and earthquake risk, if you map the three of them together, look at composite risk, you'll only find a few blocks, not few, but maybe not all the blocks in India, but 10% or 15%. So you can focus your MHPSS preparedness for those blocks. That was an interesting point. Then Colonel KP Singh yesterday mentioned 4 very good things, sir. And for an army guy to be thinking so deep, it is the credit of NDMA that you brought the army ethic and the NDMA thinking into him, sir. He mentioned that there are essentially 4 important points for any guidelines. One, it should be any assistance after a disaster, MHPSS assistance, should be timely, it should be adequate, it should be appropriate, culturally, religiously, whatever, and it should be inclusive. Don't leave the women out, don't leave the children out. So these are some of the points I have. Lucid, adaptable, malleable, and ductile, these are all very good words. So I think that's roughly it. Is there anything I left out? Yeah.
Yes.
Disabilities.
Yeah. When we talk about the accessibility, I was referring to the accessible information, accessible premises, accessible exit, rescue and all this. And always use persons with disability. Unless you use them, you forget.
Great. Done.
Unless you use the word very repeatedly, guidelines, SOPs,
Yeah, that point you mentioned. I was just remembering the point. I've remembered.
इसको जरूर include कर लीजिएगा.
हो गया.
इतने के लिए ही मैं इधर आया.
And ठीक है, I think yes, Shweta.
So this is just a reply to the person who raised the issues on livestock. So this is just to inform you, madam, that for livestock also we have some kind of shelters made. Like we have cyclone shelters, we also have shelters for livestock, and also now people are concerned about the health of the livestock as well. Not only taking them safely to the shelters, but also creating a fodder bank for them, some kind of medicine arrangement and arrangement for doctors for them. Also, Sphere India has come up with a handbook. That's a very nice one. You can refer to that. That talks about how to take care of the livelihoods during any of the disasters. So those things are already there.
Thank you. So that's built into your NCRMP too?
Yeah, yes.
Okay, and now when you make your coastal one, then we must take care of that.
Sure, sir.
Great, thank you. So we are done with this feedback session, and we are now moving to the other session which Jyoti ma'am will introduce.
मैं कुछ बोलना चाहता हूँ. Sir,
there was.
I just want to add one thing, because
a late bloomer.
Just because I heard everything. So I am a super cyclone survivor actually. I was in class 10. So NDMA was not there at that time, but we are missing, I think, the PRI members. Every panchayat has several PRI members. They know their voters very well, personally, professionally. So we also can consider them.
We can include them, yes.
Yeah.
Thank you. Great. Yes, ma'am.
Great. And the last point was somebody yesterday mentioned timely and budgeted timely and budgeted action plans, which leads us into this session, which is financial strategies for disaster mental health and psychosocial support. So we have Mr. Rizvi moderating the session with Dr. Sahil Hebar from SEWA. We've got Srimati Mandakini Balodi, who's the director of the Department of Financial Services. We've got Dr. O.P. Kansal, health specialist, the World Bank. And we've got Nikhil Pant, who's the chairman of REACHA.
Please welcome. Okay, ma'am, thank you so much. So welcome to everybody. So we have about 50 to 55 minutes for this session. And some of us have been meeting regularly, so we know each other. So we kind of know what each of us will say. But at the end of the day, it is very important that, again, a new subject within a new subject is being discussed at the NDMA level. And anybody would look at this heading and say, what's the role of finance in MHPSS? So we've got a specialist here who is the director of in DOFS, Department of Financial Services. Mandakini ma'am runs the insurance piece there. So anything to do with insurance, which is a lot, and it's many, many lakh crores that she looks at. So she is our voice in the Department of Financial Services. She understands disaster management very well. So we've invited her and she's kind enough to join us. We have Dr. Heber, who's with SEVA, who's one of the, not just a practitioner of disaster management, but he has graduated, I would in fact say post-graduated, into bringing in the word finance into disaster management. And then the NDMA was there in its recommendations on account of which the 15th Finance Commission has included disaster risk finance as an important component of mitigation. So this, all of us do know that the amount of funds that the 15th Finance Commission gave, they were divided into 4 windows, 10, 20, 30, 40, and the 20 window, 20% is mitigation. So that mitigation also includes the word finance, which also includes the word insurance. And we have Dr. Kansal from the World Bank, who is a health specialist, but I'm sure he's read up a bit on the finance part as well. And we have Mr. Nikhil Pant, who's chairman of REACHA. You call yourself REACHA?
REACHA is an NGO, yeah.
You could have added reach a child or something towards
It's an acronym.
Okay, fine. Thank you. So welcome everybody. And we will of course start with ma'am. And ma'am, you just lay out whatever you think we should be discussing and just tell us.
So I'll begin with paying my compliments to the, everybody who's gathered here to listen to the brief that you gave, sir. It was wonderful. I thought I'll begin by saying that, we should start in advance. Our attempt should be, before the disaster strikes. But all of you learned people have already made it very clear that there needs to be training beforehand, and there has to be an action at the time the disaster strikes, and then of course today's discussion, the post-stress traumatic disorder that we are talking about arising out of disasters. So sir, my approach to the problem at hand would be to build resilient communities and to inculcate a sense in the community that disaster can strike any one of us at any time. So this mindset that most of us have that, हमें कुछ नहीं होगा, we are immune. दिल्ली में कुछ नहीं होता है, कलकत्ता में कुछ नहीं होगा, बम्बई में कुछ नहीं होगा, जो होता है पहाड़ों में होता है, जो होता है coastal line, ऐसा नहीं है. In Delhi we had a recent earthquake, the tremors were felt. Then there are instances of urban flooding. Those of you who are from Gurgaon would remember there was a water logging at Honda Chowk. That was nothing but a pipeline had burst. Because of that, Gurgaon was at standstill for more than 72 hours. So disaster हमसे बहुत दूर नहीं है. So the first thing that I would begin with is to understand that disaster can strike any one of us at any point of time. So preparing the resilient mindset amongst the communities is the first thing we should start investing in. The first financial, I would call it inclusion, would be at that point. The second one, of course, at the time when the disaster strikes and how prepared we are, a part of it goes towards infrastructure that, again, Rizvi sir has outlined in great detail, 10, 20, 30, 40. So there are steps, there are interventions, initiatives which are being taken there. So there I don't have much to say. Another financial intervention that I can think of is, and of course, as again pointed out, that insurance is a part of disaster mitigation, as a part of financial tool, as a part of risk mitigation that can be adopted. NDMA has been interacting with the state disaster management authorities, And I'm happy to share that the state of Nagaland has adopted a parametric insurance solution towards excessive rainfall. To those of you who are uninitiated, parametric insurance is a form of insurance where the payout is decided at the onset of a few triggers. So if a precipitation of beyond a particular volume is recorded, then the insurance payout is made to the people. Why it is better than the traditional insurance products is because it is at a wider scale and it does not measure the individual loss. There is a set payout which is made to each and everybody affected or living in that area. So that is the difference. So this is the second stage of intervention. Today's topic, I would say the culmination and the recognition of mental side of the disaster effects or the backlash that a disaster can have alongside those of the physical ones. It's a welcome step because unlike the Western economies, the developing countries very rarely acknowledge that this is a very serious problem. And somehow culturally also we fail to see this as a big problem. Though as communities, our sense of togetherness and belongingness is very, very high. So thankfully that comes to our rescue without actually recognizing that there could be post-stress traumatic disorder. So my addition to our earlier discussions and thoughts on this, which I have just summarized for all of you, is to have, again, resilient communities where we are, of course, giving trainings, as you mentioned, and maybe a part of it could also come through the insurance programs where we are keeping a provision of these counseling sessions, of these, maybe, we are handing out maybe some kind of amount to people on account of the trauma that has been suffered by them. So that could be one way of looking at it. And we have been in discussion about creating pools. So today what I can think of is creating wellness pools involving the teachers, the trainers, the PRIs, the district authorities and all that. So who would engage in these sorts of programs throughout the year, not just when the disaster strikes, preparing people for disaster. Like we have seen so many videos, so we were talking about videos, where in Japan they give trainings, they tell school children that, if the earthquake strikes, please get inside the tables and find something to cover your heads and all that. We need more of those kinds of programs for preparedness. And that is where a part of investment can be made of this allocated disaster mitigation program fund.
Okay, thank you. Thank you, ma'am. That's, that ties in, the point you made about budgetary provisioning ties in with what Jyoti had just mentioned about timely and budgeted interventions. So good, that's excellent, insurance, budgetary. Now we'll go to Dr. Heber to share with your experience of finance in disaster management and also MHPSS.
Thank you, Rizzi, sir.
Yes,
and thank you to the NDMA and UNICEF for inviting SEWA to the event. So I'll just provide a brief background on why SEWA started working on climate finance and financing different programs in our bid for climate resilience among SEWA members. So in 2022, when there was a significant heat wave in many parts of the country, a lot of the members came and told us that the heat itself was so crippling that their livelihoods got shattered. Whatever limited financial savings and assets that they had in their name was completely depleted, and a lot of the members were forced to borrow money at extremely high interest rates. We have heard of interest rates as high as 1% per day in the street vending markets. And in other places it was like 40 to 60%. So it was very high interest, and it is backbreaking because it pushes them into the vicious cycle of generational poverty. So hence we decided that we need to have at least a few initiatives that looked at how best to develop climate resilience, especially financial resilience of SEWA members. And just to give a brief background, SEWA is a central trade union of 3.2 million informal sector women workers across 20 states in India. So they are among the poorest of the poor. Many of them are small and marginal farm holders. Many of them are daily wage earners, and hence the need for climate finance is all the more acute for this cohort. So one of the programs that we started in 2023 was a parametric heat insurance product. And as ma'am said, it is slightly different from your traditional insurance because the payouts are faster. It's much easier to enroll members, and we piloted the program in 2023 for 21,000 members across 5 districts in Gujarat. Now, even we were doing it for the first time. I think the insurance industry also was learning about parametric heat products in India. So the temperature triggers were set at a very high level, and the product did not trigger. However, members actually liked the program only because for each of the 21,000 Seva members who had participated in the program, we linked them with a climate adaptation tool. Some were given a solar light, some were given a tarpaulin sheet, insulated water jug, or a large overhead umbrella. So depending on their trade, depending on their need, members could opt for one of these 4 products. And they really benefited from that, not only during periods of extreme heat, but also when there were other climate shocks like floods and cyclones. So in 2024, when we scaled up the parametric heat product, we did it for 50,000 members across 3 states and almost 22 districts. And out of the 50,000 members who participated last year, the product did trigger because of the severe heat wave, and 46,339 members got payouts which ranged from 150 rupees to 1650 rupees. And the average payout was around 1000 rupees, 984 to be precise. And members used that for building their, rebuilding their livelihood. Some invested it back in repairing any broken equipment. Some purchased school uniform, books, stationery for their children, and so on. So it really benefited them, and most importantly, it breaks the cycle of them requiring money and going to the local money lenders. And I think that was one of the key success stories of the program. So this year, in 2025, we have scaled up the program again. We are linking almost 250,000 Seva members with a parametric climate insurance product. So it is a combination of heat, excessive rainfall, and tropical cyclones this year. So we are doing it multi-peril across 34 districts, across 6 states in India, and 2 union territories, Jammu and Kashmir and Ladakh. And along with this, we have also developed something called a climate welfare facility. So Mandakini ma'am highlighted a couple of the features of parametric insurance. What we have realized is that there are certain benefits to it and there are certain challenges to it. The key challenge is that as of now, the products are still slightly unaffordable. And there's something called basis risk, that members would have suffered significant impacts of heat even at 43 degrees. But if the trigger is set at 43.01, then they won't get a payout. So this is called basis risk, when they have suffered a damage, but they're not getting paid by the insurance company. And basis risk actually is a big problem with parametric insurance products globally. So when you talk about like the basis risk, when you talk about unaffordability of the product, when members have to contribute money towards the premium, it's a huge amount of money for them. And if the product does not trigger, then demand generation in the subsequent year becomes a huge challenge. So one of the things that we have developed is something called a climate welfare facility. And as I always do, I would like to thank Dr. Krishna ji and the NDMA for their support and for their guidance in this journey. Because what we do with the climate welfare facility is we are retaining all the premiums that we collect from members. We are collecting donor capital and philanthropic funds and creating a corpus of our own. And some of the corpus would be used to pay out members when there is a climate shock. But to ensure that the fund itself does not get depleted, we are insuring the facility. And that insurance is being purchased from one of the government insurance companies. So by having a welfare facility that is retaining risk at Seva, we feel that the product can become more affordable. We can ensure that even if the product does not trigger in non-hot years, we can give back to the community in terms of premium rebates, in terms of no-claim bonus, in supporting their climate adaptation journey, by ensuring that we work on climate health and early warning systems. So all of this is possible if we retain the risk at our end. So those are the 2 key initiatives that I would like to highlight.
Excellent, thank you. So what I would like to say in the comments that Mandakini ma'am and Dr. Hebbar have said is that you see this, what is the mental health and psychosocial angle here? It doesn't strike us immediately, but when you are giving out a payout to somebody who has just been exposed to a slow moving disaster where he hasn't been able to go to collect his daily wage because he has not been able to pull his rickshaw for the whole day, that is serious mental health that is impacted, because he is looking to dip into his savings to pull out the meal for that evening. Hence, for a slow-moving disaster like heat, which is not so visible but you can feel it, this is a very, very good product. Then the second thing is that when there are disasters, people get relief of 4 lakh rupees and various other things, but it is not timely. So if it is not timely and you get it 4 months later, so the impact of the goodness of providing that 4 lakhs goes down the tube. So that finance, which we at the macro level, we see it in big crores and this window and that window. Actual story is down there at the retail level, at each victim's level. So the speed of reaching that 4 lakhs to the victim is the most important. So that aspect we'll also discuss. But the insurance part that both the speakers on the left have mentioned and so much in detail by Seva, that is a really good example which we would like to replicate all over the country because they are a non-profit. They have not taken premium from the government. They have taken premium from a non-profit and they're doing it for the people of this country. It's a common good product that they have created. So that's one of the reasons why we invited him to tell us what's going on over there. And it is one of the best de-stressors which maybe no psychosocial expert will be able to provide except the 500 rupees that you get per day in that time when you're losing your work day. So I'll go to Dr. Kansal now. So for Dr. Kansal, he is from the World Bank, as I said, so he will just discuss some of the products they have. And the problem with World Bank is their products are very big. So you do tell us the big products and then we'll figure out how to connect them to MHPSS.
Thank you so much, Riju sir. And thank you NDMA for inviting me as well for this discussion. I am just around 4 months old in World Bank, to be honest, but of course having a reasonable experience in disaster way back in 2007, 2008 when I was in Bihar in UNICEF and flood struck, and so I've worked a lot. So one quick experience which I can narrate is related to the mental health is that when we were doing for a joint UN assessment in Kosi area, we saw that children were not able to speak. They were not willing to speak at all because it was just 2 days that flood had hit them. But then through pictures, as I was listening, that art is also one medium of expression. So they very clearly, our teams could understand that how much of stress they were undergoing or they would have undergone because not only that their family members were lost, but also for children the impact was that the school books, educational aspect, etc., everything was gone. And they didn't have any idea. I was also listening to Rajendra sir's opening address yesterday, and I draw a lot of conclusion or my personal learnings also. I strongly believe that for managing mental health, both in a normal life as well as in a disaster, it is the spiritual quotient of an individual which is very, very important. Sir was saying about one of the shlokas from Chanakya, that Pandit Chanakya said, and even otherwise. So I remember a verse from Bhagavad Gita, and in fact there are many verses from Bhagavad Gita. If I may just narrate one, that Matrish Pashast Kantya, Chitoshno Sukh Dukda, Agama Pani Anatyanto, Tantis Takshaso Bharata. What does this mean is that the non-permanent appearance of happiness and distress. See, happiness and distress, like he was also saying yesterday from references, and their disappearance in due course is like appearance and a disappearance of winter and summer. जैसे सर्दी और गर्मी आती है उसी तरह सुख और दुख आएंगे. And as Mandakini madam was also saying, that's a right fact. किसी को कब किसको disaster हो किसको नहीं हो, no one can predict it. So in that sense, what Arjuna was being advised by Lord Krishna, and in fact which is a message for all of us, is that how do we tolerate? And I remember our experience of COVID. Being a medical doctor, a lot of people used to reach me while I was not into active practice, but despite being public health. So one key aspect that I remember is those who had spiritual inclination, those who are taking shelter of the scriptures, whether it is Gita or maybe Quran or Bible, etc. Those are really taken the shelter of scripture. Probably they were better placed to cope up with these disasters in their lifetime or even for the loss of their neighborhood. When it comes to the technical, the products that Rijvi sir was saying for the World Bank, what I know is that World Bank normally, there are two scenarios immediately after disaster. One is that we need immediate support, say within 2 hours, 4 hours, 10 hours, 20 hours. Probably, as I understood from my other senior colleagues in the bank, World Bank doesn't have a strong foot in this scenario. But yes, 7 days, 10 days, or 20 days, or 30 days later, whatever the disaster has happened, what are the mitigation measures, how do we rebuild the scenarios there? Probably in that scenario, the World Bank has a great role to play. And some of the products that, in fact, most of you would know that World Bank in India is active in both at national level as well as many states. So in the states, it's a loan scenario, but then within that, there is an option of, for example, one technology called as development policy loan with catastrophe, that whenever a disaster strikes, it's like a credit card, that you apply for a loan and then within a few days, you can get the funding for whatever the agreed upon actions are. There is another product in the World Bank planning system that is crisis response window. It's like an ATM. I'll give you an example. Say, I think someone said Nagaland, yes, Nagaland Parabolic Insurance has done. So World Bank teams are, especially from a health focus, we are working in Andhra Pradesh, Tamil Nadu, these days we are working in Gujarat and many other states. Supposedly a disaster strike in any of these states where World Bank funding is already there. There's a term called as crisis response window. The funding will trigger immediately for disaster support in that particular geography, whether those districts are a part of the World Bank support in that state or not. The funding can be supported and within the state government, the actions can be taken. There's another one, immediate response mechanism. This product is like a fire extinguisher. Again, that this is a kind of a grant, that immediately you need a grant, a state requires it, then mutually agreeable, maybe within 7 to 10 days, a grant can be given to a given state, depending upon the agreeable aspects. And also taking into factor that who all are supporting it. What are the gap areas that need a grant for that? And there's also catastrophic bonds. World Bank is acting as an intermediary, just like bonds, that there are private, this is also called as shifting the risk to the private sector. That in the markets, there's a bond, and the state government is paying an agreed upon premium for services. But if a disaster strikes, the money comes to the state government and they don't have to pay any further premium, and the private party, which has agreed to pay this to state government, they will pay the money. However, on the contrary, in case there is no disaster striking and then the little premium, whatever the agreed upon premium is, the state government will continue paying that. So why is the bank involved in this? Because bank becomes an intermediate. They take a guarantee that, okay, if you're doing a bond for a given state, please do that. In case they don't fail it, bank will pay you. So this kind of an intermediary is there. And my previous two speakers have very clearly mentioned about the parabolic insurance, which is also a new concept, which is not so new anyway. The key part which I learned from my senior colleagues is that many of these options have not been exercised in India, but however, in our neighboring country, Nepal, this DDO, Development Policy Loan with Catastrophe, that was also drawn, and many other, like Philippines and some other countries. In India, the best part is, which I can very proudly say, is that Government of India actually has huge financing. Now, the only last point I want to say is regarding mental health. Probably funding is required, sure, but I would say that dedicated funding for mental health probably may not be there. If since yesterday morning all of us are discussing about that how do we mainstream mental health into our programming. Once that is done, then understood that if there are 100 rupees given to me for financing, certain amount will go for mental health management also, which is the need of the hour. So I'll stop here and maybe second round we can do something.
Thank you. Thank you very much. So now we'll go to Mr. Pant, who will tell us about stuff as it happens in corporates and CSR. What can CSR funds do? Please.
To begin with, my sincere appreciation for calling me to the NDMA, Rizvi Saab, aapko bhi. I was in the Ministry of Corporate Affairs at the IICA when the CSR law was rolled out from 1st of April 2014. और उसमें there is a clause which is disaster management, including relief, rehabilitation and reconstruction activities. It is a permitted CSR activity. So in the next 5 minutes, I will give you a structured response at 3 levels: policy and the law level, CSR ग्रांट लेवल एंड इम्प्लीमेंटेशन लेवल की हो क्या रहा है इस समय कंट्री में. एंड जो इम्प्लीमेंटेशन लेवल पे मैं खुद पिछले 10 साल से कुपवारा में बारामुल्ला में इंडियन आर्मी के संग हम काम कर रहे हैं ड्रग डी एडिक्शन इन अ कॉन्फ्लिक्ट जोन, because conflict is a man-made disaster also. I will share few lines about my own personal experience in the last 10 years. उससे क्या impact हुआ है और ONGC ने sustained funding की है, because इस topic है इस panel का sustained funding. तो ये कैसे related है उस law से, ये मैं आपको 2 मिनट में explain करना चाहूँगा. So the CSR law permits funding for disaster management and the points that I mentioned. Now what does this mean? This implies that there are 25 to 30,000 companies, 25 से 30,000 कंपनियां हैं जो हर साल CSR कर रही हैं mandated. उनके लिए mandate है ये. तो जब हम sustained funding की बात कर रहे हैं तो अगर हम mandated area में plug in करेंगे तो हमें sustained पैसा मिल सकता है. It's a matter of strategy. I would request NDMA to very seriously take it up with the Ministry of Corporate Affairs. अभी new regulations आ रहे हैं इसमें. और मैंने पहले भी डिस्कस किया था NDMA से कि अगर आप इसको embed कर पाते हैं पॉलिसी लेवल पे तो आपको sustained funding मिलेगी. लेकिन हो क्या रहा है, what is happening? In 2023 and FY 2023, the total CSR expenditure was 29,986 crores. Out of this, the money that went to disaster management was 815, which was less than 3%. So the money that is actually going in a permitted activity to CSR through corporates is very, very less. Now, how can you change this? You can change this if the policy makers within the corporate CSR committee of the board जो होती है वो shareholder money, CSR money is shareholder money. उसका जो trustee होता है वो CSR committee of the board होती है. They have to decide कि वो पैसा कहाँ खर्च करेंगे. अगर ये MCA mandate कर देती है कि अगर आपकी बजट 100 रुपये है तो आप 5%, 7% डिजास्टर रिलीफ या इस मेजरमेंट्स में खर्च करेंगे अपनी इंडस्ट्री लोकेशंस में या पैन इंडिया. इट इज़ अ मेजर रिक्वायरमेंट विच आई फील. नाउ the issue is that अगर हम implementation में भी आते हैं, so I'm finding that a lot of, because I myself run this NGO, Richa, this is since 1992, and in Kashmir we've been working since 2016 with the 19th Artillery Brigade at Baramulla, which is an aspirational district, and they asked us to take up and help them support drug rehabilitation, because वहाँ conflict zone की वजह से बच्चों को drugs करके इंसर्जेंसी की तरफ लेके जाया जा रहा था. एंड इनफैक्ट हम तो कुछ ऐसे लोगों से भी मिले जहाँ पर स्नेक वेनम यूज़ करके बच्चों को पॉइजन करके वेनम डाल के फिर स्टोन पेल्टिंग एंड AK-47s की तरफ ले जाया गया था. और हमारा ये एक्सपीरियंस है विद ONGC CSR सपोर्ट दैट ओवर अ पीरियड ऑफ 8 to 10 years it has had a massive positive impact. And a lot of those children have been weaned away from militancy and they are doing skill building courses. कोई education का course कर रहा है क्योंकि हमें कहीं ना कहीं ऐसे बच्चों को फिर mainstream भी करना है. So what is critically important in my opinion is that जब हम अगर मैं topic पे आता हूँ आज के navigating post disaster mental health, because जब disaster के बाद में जो mental health issue है वो एक major issue है and it needs a sustained funding. I think if you want CSR to participate in a more meaningful manner, नंबर 1 NGOs की कैपेसिटी बिल्डिंग होना बहुत ज़रूरी है. नंबर 2 मेरा ये भी मानना है कि जो भी CSR प्रोजेक्ट फंड किया जा रहा है, क्योंकि मैं भी प्रपोजल्स बनाता हूँ अपने NGO के लिए और मैं ग्रांट गिवर की साइड में भी रहा हूँ. आई हैव बीन विद द टेक महिंद्रा फाउंडेशन एंड आई एम एन एडवाइजर विद द HCL फाउंडेशन एज वेल. मेरा ये कहना है कि अगर हम हर एक फंडेड प्रोजेक्ट में CSR में एज अ हॉरिजॉन्टल अगर हम डिजास्टर का भी एक मैनेजमेंट कंपोनेंट ले आएँ, क्योंकि आप कहीं भी कोई सेंटर रन कर रहे हैं CSR का, कभी भी डिजास्टर आ सकता है. Each and every one should be trained on disaster management, क्योंकि it can affect anybody. Now, if this is done in a structured way, मैंने आपको बता दिया, law permit कर रहा है, लेकिन वो policy level पे companies के इसलिए नहीं आ रहा है क्योंकि अभी वो mandate नहीं किया जा रहा है. और उनको जो board members हैं CSR कमेटी को, उनको जो brief करने वाले नीचे जो executive team है उनकी समझ नहीं है. तो या तो उनमें समझ आ जाए या वो mandate कर दे MCA. ये मैं अपने experience से बता रहा हूँ because I was part of the team that made the CSR law from the ministry. And I have now been implementing CSR since the last 8 to 10 years. और हमने खुद एक प्रोजेक्ट किया है जहाँ पर डिजास्टर को हमने डील किया इन अ कॉन्फ्लिक्ट जोन. सो व्हेन वी आर टॉकिंग अबाउट दिस, आई थिंक NDMA को बहुत सीरियसली इस चीज़ को लेना चाहिए शफी जी की. अभी नए रेगुलेशन आई एम हियरिंग निर्मला सीतारमन जी कुछ नए मैंडेट्स लेके आ रही हैं. सम न्यू अमेंडमेंट्स आर एक्सपेक्टेड इन सेक्शन 135 एज वेल एज द रूल्स. इसमें कहीं ना कहीं अगर हम DRR को और मजबूती से ले आएँ एज अ मैंडेटेड हॉरिजॉन्टल, जो कि हर एक CSR कमेटी जब डिसाइड करती है अपनी फंडिंग को, वो इसको एज अ कंपोनेंट ले सकती है एंड अकॉर्डिंगली वो मनीज फ्लो करेंगे NGOs तक भी flow करेंगे और CSR team भी better train हो जाएंगे.
So why is the money not flowing right now? Because one of the 12, number 12 is disaster management.
हाँ, no, that is not the reason. The reason is शफी साहब की वहाँ पर जो CSR committee of the board में क्या होते हैं, 2 director होते हैं, एक independent director होता है, depending upon the nature of the company. उनकी ब्रीफिंग कैसी है ये बहुत डिपेंड करता है कि वो एनुअल एक्शन प्लान कैसे बनाएंगे, कि उनका अगर 100 रुपये बजट है तो वो खर्चा कैसे करेंगे अगले साल. लेकिन उनको अगर बताने वाला ही नहीं बता रहा है ढंग से कि ये जरूरी है ग्राउंड पे, नीड असेसमेंट नहीं किया हुआ है ढंग से.
सुपर पॉइंट यू कम अप विद. एंड RS सर, राजेंद्र सिंह सर और वत्सा सर और हम लोग लगे हुए हैं पिछले 1.5 साल से नॉन प्रॉफिट्स को इकट्ठा करने में. तो हमने किया 1-2 मीटिंग, 2 मीटिंग हो चुकी हैं, तीसरी होने वाली है, फिर कई इनफॉर्मली वी रीच्ड आउट with this objective that number 12 entry in the CSR is disaster management. So please invest in disaster management.
Right.
So we found very lukewarm response.
Yes, you would have done that. Absolutely.
And we kind of showed presentations also. Glacial lakes में ऐसे हो रहा है, ये हो रहा है, but there was lukewarm response. Then one thing that we came up with, maybe the reason why the boards are not interested, is because everybody climate के ऊपर इतना massive marketing हो चुकी है that climate mitigation in which you reduce GHGs.
क्योंकि वो ESG reporting में भी दिखाते हैं.
तो वो ESG reporting की वजह से everybody is doing climate में, and then you don't know how to reduce GHGs, so you start doing capacity building.
Absolutely.
Now capacity building means 20 people come, 20 people have dinner, lunch, and then they go away, they get a few classes. So it's not stable money, it doesn't stay, it doesn't sustain.
Yes.
So we try to push them into new technology, into difficult areas, like go to the mountains and वहाँ काम करिए. लेकिन धीरे अभी हो रहा है, it's too slow. So we are unable to figure out how to speed it up.
नहीं तो शफी साहब मैं आपको तरीका बता रहा हूँ. I'm just hitting the nail on the head because I worked with the army, and when you should kill the militant. So the only way is if the MCA in the new regulation mandates that अगर आपके पास 100 रुपये बजट है और अभी 2.7% पूरी कंट्री स्पेंड कर रही है CSR में, 800 करोड़ रुपए आप खर्च कर रहे हैं 30,000 करोड़ में, 25,000 कंपनियां हैं कंट्री में जो CSR कर रही हैं. अगर वो मैंडेट कर देते हैं कि अगर आपकी बजट 100 रुपये है, तो अभी टिपिकली व्हाट द कंपनीज आर डूइंग, बिकॉज वी डू अ लॉट ऑफ डेटा एनालिसिस कि मनी कहाँ जा रहा है, वो टिपिकली 80-90% अपनी लोकेशंस पे खर्चा करते हैं जहाँ उनकी फैक्ट्रीज होती हैं, और 5-7% कोई कंपनीज होती हैं जो आउट ऑफ द लोकेशंस करते हैं. मेरा ये कहना है उनको समझाने समझने में तो सदियां निकल जाएंगी. अगर ये मैंडेट हो जाता है, क्योंकि एनीबडी एंड एवरीबडी कैन बी अफेक्टेड बाय अ डिजास्टर, तो जब वो एनुअल एक्शन प्लान इसी वक्त बनाते हैं, ये आपने बहुत सही वक्त पे ये सेशन कर रहे हैं, क्योंकि अभी इस साल का F5 25-26 की एनुअल एक्शन प्लान्स बन रहे हैं और अप्रूव हो रहे हैं, और इसमें 30,000 करोड़ रुपए सैंक्शन किए जाएंगे 25,000 कंपनियों के द्वारा, और अभी वो केवल 800 करोड़ ही देंगे, और उतना भी देने तो बड़ी बात है. मैं ये कह रहा हूँ कि अगर ये MCA ये कह दे कि आप 5% अगर आप कर दें, आप 2.5 से 5, कुछ तो 0 कर रहे होंगे, कुछ शायद 7-8 कर रहे होंगे, तो वो एवरेज करके 2.7 आ रहा है. आई एम सेइंग इन द न्यू रेगुलेशंस व्हिच निर्मला सीतारमन मैम ब्रिंग्स आउट, अगर MCA थ्रू IIC, आई वाज इन IIC फॉर 5 years, इट इज़ प्रीटी डूएबल. इसमें कंपनीज बहुत हल्ला मचाएंगी, वो होगा ज़रूर, पर जब 2% लॉ भी आया था तभी भी हल्ला मचाया गया था, पर आफ्टर 10 years एवरीबडी इज़ वेरी हैप्पी विद इट.
So why I ask you this question on behalf of the finance ministry, that why should we mandate for disaster management and not the other 11?
Yes, so very relevant point. So therefore हमारा जो pitch होना पड़ेगा NDMA की तरफ से, वो बहुत strong pitch होना पड़ेगा सर, क्योंकि pitch में इसलिए important कह रहा हूँ क्योंकि जो spending है वो typically need assessment basis होनी चाहिए. तो जो हम नीड असेसमेंट प्रेजेंट करें NDMA की जो मैपिंग है डिजास्टर जोन्स को लेके, उसको हम अगर मनी में क्वांटिफाई करके बताते हैं और उसको हम प्रोपोर्शन ऑफ से एजुकेशन में 40% जा रहा है, हेल्थ में 30% जा रहा है, विच इज़ आई एम नॉट सेइंग कि वो नहीं जाना चाहिए. मैं तो ये भी कह रहा हूँ शफी साहब कि आप अगर हेल्थ में 40 रुपये दे रहे हैं 100 में से, तो उसमें भी आप एम्बेड कर सकते हैं डिजास्टर का कंपोनेंट एज अ सॉफ्ट स्किल, एज अ हॉरिजॉन्टल. मैं कह रहा हूँ स्टैंड अलोन मत दीजिए, आप चाहे वर्टिकली मत दीजिए, आप हॉरिजॉन्टल भी एम्बेड करके इस परसेंटेज को बढ़ा सकते हैं. तो समवेयर आई एम सेइंग इट नीड्स टू बी ब्रॉट इन, बिकॉज डिजास्टर जब आता है तो फिर सभी लोग अफेक्ट होते हैं, एंड इट इज़ अ यूनिवर्सली रिक्वायरमेंट, और उसको हम थोड़ा सा स्ट्रक्चर्ड मैपिंग करके प्रेजेंट कर सकते हैं मिनिस्ट्री को.
So by means of this seminar we are co-opting you in our gang of pushing this, and we will do both things in parallel. We will also speak with the finance ministry, and we will try and push the mandatory part if we can. Otherwise, we have to do the Sadiyo long wala thing.
We have to keep doing it. So
you
there are
have
some
to help us
companies.
in doing that.
So like we've got HCL Foundation is here, like
We have
Chetna,
already
so they are
been
doing it.
prospecting with Dr. Chetna. Where is she?
She's there at the back.
So we've already prospected her. We've connected her to Arunachal Pradesh for glacial lakes.
They're doing a lot of work in the northeast as well.
Ma'am, lots of pressure on you now. Now you cannot back out of glacial lakes. And you are on Mahindra Foundation.
Yeah. So I also engage with a lot of corporates. So typically क्या शफी साहब मैंने देखा है कि ऐसा नहीं है कि वो एवर्स हैं. मुझे ऐसा लगता है कि उनको सही तरह से ब्रीफ नहीं किया जा रहा है. तो हम ये सदियों वाला भी कम सदी भी हो सकता है.
एक ऑनलाइन 100 लोगों के लिए कर सकते हैं.
हाँ, ये बिल्कुल हो सकता है. और मेरा मानना है कि इसमें बहुत डेडिकेटेड एफर्ट की जरूरत है. उधर मिनिस्ट्री को भी धक्का लगाया जाए, इधर से यहाँ भी जाया जाए. दोनों तरफ से हम आगे बढ़ेंगे.
Yeah, please.
I was, until 1.5 years ago, I was in a corporate sector only, Becton Dickinson, multinational company, and I worked there for 12 years. So, and incidentally, for 6 years, I was looking after CSR wing also of the company. तो मैं उस पहलू से आपको बता रहा हूँ कि जब हम CSR जो अभी बात कर रहे थे कि बोर्ड साहब not officially but I was a part of the company's decision making thing. We receive proposals. कंपनी वाले क्या देखेंगे कि इम्पैक्ट क्या आएगा. इवन इफ इट्स अ डिजास्टर, आई विल गिव यू द कोविड एग्जांपल. कोविड के टाइम में बहुत प्रपोजल आए कि जी आप ये पैसा दे दो, ऐसे कर दो. उसमें क्या आता था जी, इंफ्रा दे दो. जैसे पल्स ऑक्सीमीटर है, सबसे ज़्यादा डिमांड इमीडिएटली आई कि पल्स ऑक्सीमीटर्स नहीं है, इस जिले को ये दे दो. गुरुग्राम, वी वर बेस्ड इन गुरुग्राम, मजबूरी में दे दिया, चलो रिलेशनशिप बनाना है. बट द पॉइंट इज दिस, उसका इम्पैक्ट क्या आया हमें नहीं पता. 500 पल्स ऑक्सीमीटर कहाँ गए, कितने लोगों की लाइफ सेव रही, क्या हुआ, कैसे हो, कुछ नहीं पता. So मेरा जो पॉइंट है, मेरा रिक्वेस्ट है, I know there are members from SDMAs, there are of course NDMAs there. So if in parallel to the effort that we have discussed and agreed upon, the impact will also come if you have ready proposals that shows कि अच्छा इतना पैसा अगर आप donate किया CSR का लगाओगे तो ये impact आएगा. So many lives saved, so many this thing that वो mathematics करने में आपको help
मिलेगी. In fact, कंसल जी आपने मुझे एक्साइट कर दिया थोड़ा और डीपर जाने के लिए. मैं एक पॉइंट इसी में ऐड करूंगा. उसमें SROI कह रहे हैं आप, SROI, क्योंकि जो डोनर्स हैं वो ये चाह रहे हैं कि इम्पैक्ट को आप मेजर कर सकें सोशल रिटर्न ऑन इन्वेस्टमेंट्स के बेसिस पे. तो अगर जो कंसल साहब कह रहे हैं कि कितने लोगों को आप बचाएंगे, वो भी एक इम्पैक्ट, हम अगर NDMA के हेल्प से कुछ हम वो इम्पैक्ट पैरामीटर्स को फर्दर स्ट्रक्चर्ड वे में क्वांटिफाई कर सकें.
हम भी इतने एक्साइटेड हैं, आई वांट टू स्टैंड ऑन दिस टेबल एंड से विप्पी. So let's make a.
तो ये अगर करेंगे तो ये क्रैक हो सकता है.
So do we have a proposal that is put up to any company? We won't leave.
या सो प्रपोजल्स DRR के तो मिल जाएंगे बिल्कुल. हाँ बिल्कुल हम आपसे शेयर कर लेंगे. इनफैक्ट आई रिक्वेस्ट चेतना एज वेल, एंड इनका तो पूरा फंडेड प्रोजेक्ट
आज ही भेज दीजिए और उसी पे ट्यून करके हम लोग अपनी तरफ से ड्राफ्ट सा बना देते हैं.
बिकॉज आप बिल्कुल सही बात कह रहे हैं, क्योंकि वो जो बोर्ड मेंबर्स हैं वो इवेंचुअली ये कहते हैं कि हमारी ब्रांडिंग क्या हो रही है और हमारे को रिटर्न ऑन इन्वेस्टमेंट ऑडिट, क्योंकि वो ऑडिट पॉइंट से देखते हैं उसको थोड़ा.
प्लस दी अदर थिंग इज, जैसे SDMAs है, आई थिंक NDMA एंड प्लस इनकी हेल्प से प्रॉब्ली अ कोचिंग सेशन कैन बी डन फॉर द SDMAs आल्सो, कि उनके भी प्रपोजल रेडी होने चाहिए. बिकॉज फंडिंग जो होगी सर वो नेशनल लेवल से नहीं होगी, वो स्टेट लेवल या जो कंपनीज लोकली हैं, जैसे इन्होंने बताया.
CSR can fund SDMA also.
Yes. वो तो CSR can fund a state government also.
नहीं CSR गवर्नमेंट को पैसा नहीं दे सकती. CSR आपको 1860 को दे सकती है, ट्रस्ट को दे सकती है, सेक्शन 8 को दे सकती है.
Sir, but you can make a public-private partnership for the DRR also.
There are 3 types of entities. वो डायरेक्टली स्पेंड कर सकती है, वो PM टाइप की फंड्स को दे सकती है, कुछ गवर्नमेंट की जो गिवन फंड्स हैं, या वो इन 3 टाइप के NGOs को दे सकती है, सेक्शन 8, ट्रस्ट या 1860 सोसाइटी.
So इसी just to add to that, अगर proposals बनते हैं, and you can count me in proposal writing support करने में, but proposal अगर बनेंगे, then SDMAs are concerned, as soon as a disaster strike, they can reach out to the local companies and then maybe they can, state government will not receive the money. पर जैसे इन्होंने बताया डायरेक्टली जहाँ चाहिए वहाँ पे पैसा लगाओ. Now coming to the current context, psychosocial support के लिए mental health वाला component, as I was saying, it should be a part of that whole plan कि मेरे mental health का component ये let's say 10%.
कंसल साहब थोड़ा अंग्रेजी में बोल दीजिए.
Sorry. So for mental health also, as a part of the entire CSR plan, it should be embedded in the plan that okay, if I'm asking for 100 rupees, 10 rupees will go to this supporting the mental health in the traumatic phase after disaster, and for that purpose, maybe with that, how much of life saved or how much of the financial gain or whatever way we want to measure the mental health impact, those indicators need to be put up. So
Okay,
the
great.
result-based management concept need to be applied while writing the proposal. Thank you.
So, we've already voted this session number 7 as the most excited session. So before, okay, we'd like to travel to this side also. We have
एक
15
लास्ट पॉइंट मैं
minutes.
आपको बोलना
Just
चाहूंगा सर
hold it, just hold it.
एक सेकंड अच्छा चलिए एक बिल्कुल बिल्कुल जस्ट हैज टू कम आउट एक अगर आप एनडीएमए की तरफ से कॉर्पोरेट वर्कशॉप भी करें if we can do a corporate CSR workshop as well
We are ready.
where the audience is all corporate decision makers then we can create that pitch to give them the logic which Kansal Saab was just saying ki that SROI can be pretty high if you do it in a structured manner. It is pretty doable.
It's called SROI.
Social return on investment, SROI.
Okay, cool. So we will do one.
Thank you so
very much. Yes, ma'am. So how does Ministry of Finance react to this excitement?
We are very excited. CSR tweaking could be an idea that could be floated. I'm only wondering whether, there would be acceptance towards making slots within the slots. So, but if that happens, it's wonderful. I would like to add an enabler though in this proposal. We are talking about measurable outcomes, we are talking about holding workshops, we are talking about asking them to spend on disaster mitigation. I would say that if there is some kind of a channel which could be formed between these organizations, the corporates, and the NGOs who are actually doing such work on ground, that would also help, because sometimes the organizations do not know where to spend, whom to approach, who would do this work, who would present the proof of concept to them. So if that kind of an enabling provision or a channel can be created, that would help. Usually when companies spend on CSR, it is largely, as pointed out, within their district, because that is where they want to build the confidence among the local communities and increase local participation, which is not a bad idea per se, but then yes, it can always be enlarged to serve a larger piece of population.
Great. Thank you, ma'am. So, Dr. Heber, in your experience, before you went to a non-profit for the premiums, did you go to CSR for premiums?
We did. Sorry. So we did, but again, it's very difficult unless there's a platform that actually enables that interaction between the CSR funding organization and the NGOs or the civil society organizations. I think it's easy to create a proof of concept, it's easy to socialize it, but then to reach out to the right people in the absence of such a platform becomes a big challenge. And I think even if we do have this platform, one key enabler to ensure that such programs are successfully deployed, ultimately for the benefit of the community, is that the community itself has very limited knowledge about a lot of these concepts. So we are talking about climate finance, and we are talking about parametric climate insurance, contingent lines of credit, index loans. There are so many new terms that can help low-income communities during times of climate disasters. But they have absolutely no idea what some of these concepts stand for. आप अगर इंडिया में जाकर अभी किसी से पूछे कि parametric heat insurance, what is parametric heat insurance? Very few people will be able to tell you what exactly that is. So unless we are able to articulate clearly what exactly heat insurance is, how it benefits, how a parametric product is different from indemnity product, what are contingent lines of credit, what are index loans, limited point being, there's a huge capacity requirement even at the community level, and unless we bridge that gap, even if we do have successful pilots and proof of concepts, people who really need to take advantage of that will not be able to take advantage of it. I think, again, it goes back to the capacity building requirement, that we were
point
talking
about
earlier.
awareness, and if you have a hot year this year, as we discussed, you will have more payouts, so next year you will have a better program, and if we do not have a hot year, then you'll have less payouts and you may not have good reach out for your program. But that's a very well made point, thank you. So we did about last year, we were Dr. Krishnawatsa and our financial expert, I should say Dr. Shishir Agarwal and Sumanta Sahu is there from UNDP. We got together to look at alternative means of finance for disaster risk finance. So in that we had invited MCA and we had discussed about CSR. So the issue that they mentioned was, do you remember, Shishir, exactly what they said in their response? If you don't, then you're dead. All the hype.
No,
I've
sir,
given you.
they mentioned that because the provisioning for disasters is already there. So they mentioned a kind of word that CSR shouldn't be used for allocating something which is already there.
Excellent.
In
Yes,
addition to it, sir, it is also they highlighted that CSR money cannot be used as a premium.
They didn't mention premium, did they?
No, they didn't mention. Sumanta is telling that.
Sumanta has added his interpretation. Sir, you want to say something?
No, I think the real problem is that disaster management has been lumped as just one set of activities. It has not been disaggregated properly. Disaster management includes a wide range of activities, including the psychosocial services. So the connotation of the disaster management is not properly conveyed through the entry that is available right now. So that needs to be expanded.
So, sir, last year when we had that conference, the term there at number 12 was disaster management. What he has just read out is something slightly different.
I have read out exactly from the Schedule 7. So I will again read it out.
He said relief, rehabilitation, and reconstruction.
It's all part of it. So I will just read it out again. Just give me a second.
It's entry 12?
It's entry number 12, yes. I will just read out because we should know the exact Gazette notification, the nomenclature of it, because then you're not kind of beating about the bush. So the exact is disaster management, including relief, rehabilitation and reconstruction activities. So these are all permitted. So I think what NDMA could do, sir, is this कि उसकी formulation अगर हम सही तरह से करें और वो deeper embedding की strategy बनाएं. If the deeper strategy for embedding could be developed, and then we engage with corporates and NGOs to kind of.
So why this was done, this tweak, is because we had told them that the problem that in the CSR, the corporates were saying was that it does not get cleared because whatever program we take, it's open to interpretation that is this for disaster management or not. So then the MCA went and added these 3 terms to make it clearer. So when we have that interaction with the corporations, then we will finally understand that what is to be done.
And sir, I'll add another thing because I work very closely with the Institute of Chartered.
knows no bounds.
So,
Please add.
Sorry, sir. Actually, I also am a visiting faculty with the Institute of Chartered Accountants. I train CAs on CSR audits because a taxation audit is different from Section 135 audit. So the reason why a lot of corporates do not allocate money is the fear of an audit red flag. So if we can get the ICAI on our side as well, when we are doing this capacity building, that the auditors are also saying that this is okay to do, then the donor or the CSR committee head is not worried about vigilance and the red flag on the audit. That is also a very important thing.
Super point. So Shishir, you've got your work cut out now.
Yeah, I fully agree with him because as I said earlier, being on the company side, I knew that the board will also have a fear of the audit.
Absolutely.
That how will it be seen by an audit? How will they measure this as an impact?
Okay, excellent.
A big gap, sir, is, sorry, sir, a big gap also is, sir, the NGOs in their constitution of their memorandum of associations do not have these things as permitted activities. So if an NGO comes with a proposal who is not permitted for this, that NGO should not get the money, even if the donor wants to give him. Again, an audit red flag. So the NGOs need to be very clear about their MOA objectives, aims and objectives as well.
Okay, great. Thank you. So we are heading towards the end. Any final words, ma'am, from the Ministry of Finance?
Nothing to say as such, sir. So this is a policy decision, fine-tuning the wordings of the Act. Usually, the policy perspectives are larger, and they are kind of left open on purpose. That's the usual take. But then, I hope better wisdom prevails. And again, I would just say to conclude what I've been saying during this session is that we need to look at disaster mitigation, especially in terms of mental health well-being, at 3 different levels. Before the disaster strikes, the preparedness for the disaster, the open mindset that disaster can strike any one of us at any given point of time. So, and just because it has not struck us for 100 years or 150 years, only means that it's going to strike us with greater force and greater severity. So that is one aspect. And another is, of course, as I said, at the time of quick payouts, at the time of disaster. And third is including more financial strategies by way of pools by way of insurances where we are incorporating the mental health component, the payouts for trauma, for payouts for counseling therapies in the post-disaster scenario. And the fourth point that I made after Mr. Pant's wonderful inputs is that we need to have a platform, a channel where, as Dr. Hebar also pointed out, a channel where the two ends can meet so that this entire process get facilitated.
So I guess everybody's looking at us when you talk about a channel and a platform and a bridge. Yes, please.
So, Rizvi sir, I think in the last 5 years since I've joined Seva, the biggest realization is how siloed everything is. And unless we are able to bring facilitation between the different players, whether it be industry players or CSR or government or civil society, it's very difficult to accomplish anything. And that siloed approach and the need for integration works even in terms of the activities that we do. So if we take just climate finance programs to the vulnerable populations, the chances of it being successful are very low because their needs at that time could be mental health, it could be NCDs, it could be education. So I think there's a huge crying need for a more integrated and holistic approach that addresses multiple requirements rather than having a very programmatic and siloed approach.
That's 5 years of experience in one word. Excellent. Thank you. Yes, please.
So during the preparation phase or say non-disaster phase, whatever education we do to mental health, one is that mental health should also be a part of the regular national program. They are already there. We just need to tap it on. Secondly, as I was mentioning a while ago, strengthening the spiritual quotient, I strongly believe that will also ensure that individuals cope it up better. And of course, then if there is a disaster and financial support is there, and as a global team or as a part of the team, World Bank also can support it. So I think we need to be prepared, and then whenever requirement is there, we are there to support. Thank you.
Sir, Shafi sir, आपको 4 steps के homework दूंगा मैं आपको. Oh, sorry. So I'll be happy to help you in that. The first homework is the deeper need assessment mapping on disaster risk reduction, because CSR money is based on need assessment. So ground up, if NDMA can do that need assessment, number one. Number two, capacity building of NGOs and people who are decision makers in CSR. Number two is that capacity building. Number three is advocacy at CSR decision maker level. And number four, obviously, is the mandate ka dhakka to the ministry.
Okay, great. Thank you.
4 key steps. If we can do this, this can go from 2.7% to 7% in 5 years.
If I can just dole out money from that pocket also, then everything is done. But anyway, thanks a lot. And I definitely agree that this was the most excitable section of this entire MHPSS workshop. And I was myself, as I said in the beginning, thinking that how does finance fit into MHPSS and vice versa. But the very fact that for a slow onset disaster like heat, we have a non-profit which has demonstrated that you can get a payout for the day of work that you have missed because of excess heat. That in itself is a very good resolution to the stress that has caused you. If after the new product that they are starting, in which they have made it multi-hazard and they've got a cyclone and high precipitation in it, so if there's heavy rain and you're not able to go out of your house and there is a parametric payout that comes to you next day in your bank account, that would be a great de-stressor. And those are the micro level, retail level solutions that finance offers for an MHPSS issue. And at the macro level, I don't think anybody will forget the discussions we've had, so I don't need to reiterate that. So thank you so much, and very nice of you to join us today. Thank you again.
Thank you.
Oh, wait, we have to give you plaques.
Yeah, may I please request Rizvi sir to offer mementos to the panelists.
Mementos?
Great. Now in record time, we are at the closing session. To start this off, we have an overview of the technical workshop that has been happening over the last 2 days by Rizvi sir. Then we have a special address by Ms. Soledad Herrero, who is the Chief of Field Services from UNICEF. We have the valedictory address being offered by the DG of NDRF, and closing remarks by Dr. Vatsa, member NDMA. Can we have Dr. Rizvi on the dais, please? Sorry, Mr. Rizvi. Apologies. Apologies.
So, should we call everybody on stage?
Could we have all the dignitaries on the stage? Great. Dr. Vatsa, can we have you on the stage as well?
Okay, so welcome to Mr. Piyush Anand, our chief guest today, and our co-chief guest, Madam Herrero from the UNICEF, and we have Mr. Rajinder Singh, who should now be called a Dr. Rajinder Singh, and Dr. Krishna Vats on stage, who are our HOD and member of NDMA. We have learned so much in disaster management now. Every day we discuss 4 to 5 hazards in detail. Hence, our MHPSS is always an issue. So we get Dr. Ghanishta Suri to give us some counseling at the end of the day. So what I shall do very quickly, I could have possibly made a presentation, but there was a lot of excitement, as you have seen on the stage, so I could not. So I will just verbally tell you what were the overall things that we discussed, and we will be putting it down in a knowledge compendium in a few days from now so that we can archive it. One of the reasons why we've done this workshop is because we wanted to bring everyone together. And can we have that screen over there to show that coder thing? So I never cease to mention this point about coder. It is because we are trying to institutionalize this committee on disaster risk reduction. We have created one for almost every hazard so that we discuss earthquake in a focused manner, we discuss MHPSS in a focused manner, and we do one of these workshops every year. So if we do that, the second year, well, Dr. Krishna Vatsa is one of the most hopeful people on earth. He says do one every month. So, I mean, not much of us will be left in that. So anyway, so at least once a year we've started off, and once a month we do one for every hazard. So 12 or 13 of these coders, and we will have it all covered. So it is to institutionalize, that is one subject, and to break the silos, make everybody communicate, the center with the states, center within itself, states within themselves, is the second most important objective. And the third biggest objective is to get something out of it rather than just write guidelines and just write modules. Do something on the ground and implement it. So this is the reason why we do this. Now, what we discussed in this workshop were several specific things which I will not delve into, which are for basically the language of the experts. We did not really discuss each and every aspect of the mental health and psychosocial, the science of it, because that was not what was required. What was required was what you do post-disaster. So several intriguing and interesting sessions. So I'll just quickly mention whatever came out. We had very good representation from our key collaborator, Ministry of Health. We had their additional secretary, three joint secretaries, and 3 directors who were participating. Most of them were there yesterday. Their sessions were yesterday. We had very, very enthusiastic support from UNICEF, Mr. Sahota and Jyoti. Is Jyoti a Dr. Jyoti? Okay, she's Dr. Jyoti. And we had and Ma'am Herrero is here, so very nice of you. For the first time, we got the NDRF out of its shell. They were a bit concerned as to what they will be able to say in an MHPSS workshop. But we had very good participation from Dr. Abhishek, and I'm sorry I didn't get your name. Dr. Amit. So we had very good participation from them, and we have Mr. Piyush Anand, who's the head of the force over here. So the points made quickly. Psychiatrists in India, as per MOHF, Ministry of Health, are just 1,500 professional ones, people who can counsel. They have trained total 2,000 people. However, they found that one of the best ways of amplifying this was through 11 lakh teachers. By reaching out to Ministry of Education, and through teachers, you can get the psychosocial first aid going in a trice, because 11 lakh teachers are there all over the country. So that was a very good thing about resource pool. Then the Telemanas activity, that the mobile-based connectivity, there's a system called Telemanas, which the Ministry of Health operates. It's like a helpline. Earlier it was one way, and now it has been made two-way. This, if it can move up to becoming much more mobile and on a mobile phone, basically app-based, or if it can move to becoming a video conference call, it will be of great help. So we've discussed this with MOH, and if we can take that forward from just health, we can add the element of MHPSS to it as well. Then the guidelines were universally mentioned as too long, and so we have got 1 or 2 volunteer persons, as well as I think we'll put together a team to figure out how we can reduce all these guidelines into something which is very readable and doable for a district collector in every district. So if a disaster comes, he just Googles and puts out that 1 page or 2 pages, and he knows what to do with regard to MHPSS. Then the Joint Secretary in the Ministry of Health mentioned an important point, that MHPSS help, which is professional, reaches the victims maybe 24 hours later, 48 hours later. The first responder should also be oriented towards PFA, which may not be very intense, may not be something that is very deep, but it should definitely be in the right direction. So for that, the role of NDRF, the role of SDRFs, the role of the police, the home guards, the civic administration, the medical personnel that go there. So we have resolved that in our recommendations, we shall be writing that PFA should become a part of the first responders courses as well. And we were informed by the NDRF that they have a 19-week basic training course. So we will recommend to DG NDRF that if a small module of MHPSS can be introduced in that basic course, that would be excellent. Then we basically discussed, so this was the point made by the Joint Secretary of Ministry of Health, and he was focused very much on this, and I think it's a very doable thing. Then people with disabilities and livestock. What do you do with livestock post-disaster? Because it's not just the livestock on its own, it is the owner of the livestock who would not want to move without his or her livestock. So that was an important point, what to do, how to make guidelines and everything available to people with disabilities, what they should do with regard to their MHPSS issues. This also came up and needs to be addressed. A very important point that came out was that we should not re-traumatize the victim. By asking the victim, please tell us exactly what happened to you, is the worst possible thing possible, as all of these experts have told us. So we believe you, and as a community you have sent it, so we will basically follow this line that re-traumatizing is going to be a pretty bad word for us. Then we picked up the term trauma voyeurism, which means that the media coming and asking, aapke saath kya hua, what happened when the flood came, how did the water come, and whatever. So how we can deal with that is something we have to figure out. Then art. The involvement of art as a kind of therapy for MHPSS was brought in a very forceful way, and it was something which struck most of us as a very good thing to do. So that in itself, it goes off into our training modules, would be a very good idea, because at the retail level, every village has an artist, every village has a kid who can do some kind of good art. So maybe things like that could be thought about. Then timely and budgeted action plans. Then another important issue came up that immediately after a disaster, in some locations you have 250 non-profits that landed up that we want to help in MHPSS. So it becomes very difficult because the same person is approached by 5 different non-profits, not a good idea. So how to deal with that situation? So we came up the idea of resource mapping. Some organizations, some SDMAs have resource mapping. Government of India has a resource mapping for logistics. So we'll see how we can bring that together to do resource mapping through the digital route in a focused way. NIMHANS offered its services, so we will be working with you on that. They are already working with the Ministry of Health on a real-time bulletin board. The Bureau of Police Research and Development has also reached out to NIMHANS to include this module in its course, so that will address the point about the first responders getting some PFA training. Coordination and breaking down silos and all was spoken of quite a bit. Respectful treatment was an important point that came up, that many times the treatment to the victims is not very respectful. We tried to identify was there a community of responders who was disrespectful. So it turned out that those who are completely overworked and overwhelmed and do not have that many resources, at times medical professionals, so there is a bit of disrespect that is seen in them from what the people on the ground have seen. Another very good thing that UNICEF mentioned was that if you're not able to do any good, do no harm. That is an important point. YouTube videos, instead of just running around capacity building for 20 people courses, you can have very nice YouTube videos. One non-profit present here told us that they already have 3 to 5 minute YouTube videos. Those are very good. It'd be good to popularize things like that. Then finally, we had that fantastic session on finance, in which we have got an excellent idea on how to push CSR. We will be doing that. And we would like to encourage more non-profits, like Seva told us about its case. We would like to encourage more non-profits to get into such solutions to essentially an MHPSS problem. So that in a nutshell is what was discussed. Thank you so much for all the important speakers and our guests right now. So I will request Jyoti to take over. Thank you.
Thank you very much, Rizvi sir, for that comprehensive overview. Now might I request Ms. Soledad Herrero, who is the Chief of Field Services for UNICEF in India, to deliver her special address.
Thank you, first of all, for a clapping before intervention. That's a good start. So, Mr. Rizvi, Advisor of NDMA, thank you so much for convening and steering this process, as well as Mr. Anand from NDRF, my other colleagues from the panel, Mr. Balsa, NDMA, and Mr. Rajendra Singh, also from NDMA, from my understanding. It is really such a pleasure to be with all of you discussing an agenda that is actually really close to my heart, and it really intersects two field areas in which I've been closely working for the last 20 years in my career. I've spent most of my career in emergency context. I've worked in both conflict-affected areas, post-peace processes. I've worked on issues such as the mobilization of child soldiers. I've been in emergencies related to cholera, to Ebola in East Africa, and in many other contexts as well, in the separation of Sudan and South Sudan. So I do understand the significance and the role that the emergency apparatus has in the well-being of a nation. So I really want to start by recognizing the role that all of you have, especially spearheaded by NDMA, but the different parts, we have the law enforcement, we have the role of the CSOs to really recognize the criticality of the mandate that you have. UNICEF is here, and maybe I thought that we should start also to explain why for UNICEF this agenda is central. The estimates have just been revised globally, and a recent Harvard study has pointed that in the life course of a person, there is a 50% chance of suffering one mental health disorder or other, right? So if we look around, 50% of the population in India as well is likely to suffer some mental health condition at some point. But now is where UNICEF comes in. Around 50% of those mental health disorders are going to be established before the person reaches the adulthood. So the primacy of focusing and having a strong focus on children within this agenda is absolutely critical. I think my understanding is you've already been discussing the state of affairs. There is a very strong policy framework and important advances from many of the ministries, but we know that there is still a long way to go, and I think Mr. Rizzi already was pointing of some of the gaps in terms of the coverage and ratio in the mental health spectrum. Now, if we understand the importance of the MHPSS agenda in general, it is also critical that we also reflect why the mental health agenda is even more important in a context of emergency. And again, I speak from what data is talking about very much from experience of many decades working in many emergencies in different parts of the world. An emergency will almost certainly affect the well-being of the population. That is just a given. So whenever each of you work in an emergency context, you do have a situation in which the mental health of the population is unavoidably being affected. Now, while this is true, it is also equally true that by certain level of interventions, you're going to be able to curb a significant proportion of how the population is affected. And I also want to explain here that it might not necessarily be by specialized mental health and psychosocial support interventions. There is some global data that shows that around 80 to 90% of a population that is struck by an emergency might not develop mental health disorders if, and this is an important if adequate support is provided. So I also want to bring the significance of the role that you actually have in preventing mental health conditions to unfold in an emergency situation. So don't think that your role is actually secondary, because it is extremely central. If a person that has lost lives and family is able to grieve adequately, it will be a natural process of grief as opposed to evolving into something something different. So it is really a two-way situation. It's not only about you enabling mental health and psychosocial support services to reach the population, which is important, but it's actually, you do have a very substantial role in the well-being of the population that is being affected. And how the emergency is conducted is going to have a very strong influence on what is the repercussion in terms of the well-being. Very animated session indeed on the finances, and I think for very good reasons, because I think there is a very, very strong case for an investment on the mental health and psychosocial support. Very, very strong case. The return of investment in parenting programs, for example, at early ages that allow parents to provide adequate support to children is significant. The return in investment in some community-based counseling in an emergency setup, it is of high significance. As UNICEF, we oftentimes create child-friendly spaces, so there is a sense of normalcy in the middle of an emergency. It's not expensive, but if you create a space for playing, and by the way, let's not forget that the main duty of a child for development is play. Play is not an extra condition. It's a need for a child, for normalcy, for development, even for neurological development. So all these need to be factored, and it is extremely important that when we look at the MHPSS agenda, we see the strong case for an investment case, and we also recognize that this is not and cannot be an afterthought. I think colleagues, and there is some data about the ratio of investment in social workforce and how much of the health program invests, for example, in mental health, that needs to be revised. There are no miracles, and I'm glad that the Minister of Finance is here, because you need adequate resources to yield adequate results. As a way of conclusion, just a couple of considerations as we move forward. I think that there is little to add thanks to the excellent summary that Mr. Rizzi offered, but a couple of reflections maybe more at the broader level. First of all, the importance of what this workshop has already been done. This agenda needs to be visible. We need to talk much more, and we know that especially after the COVID, there was a very important awakening to the realization. And I think it's staggering the data that I just offered, that half of the population is expected to suffer some sort of medical condition. This is the relevance of the agenda, and this is how important it is that in our distinctive roles that we all have in this house and beyond, we do recognize that mental health has to be much more central to a lot of the discussions from the development, from the human rights perspective as well. Second, I really appreciate the effort that is spearheaded by NDMA. You're bringing in the reminding ourselves that this has to be a multi-sectorial action. I think it was great to see that the collaboration with Minister of Health, as I said, there are other CSOs and other entities here, and I really look forward for NDMA coming together with other ministries as well, because if it's not owned and it's not well coordinated, we are not going to be able to yield necessarily the results that are expected. It is also important, and listening to the third point, I'm sure you might have sort of discussed the pyramid approach to MHPSS intervention, in which you move from preventive, community, non-specialized interventions to the specialized, right? It is important that that pyramid is there, and different departments and different institutions will play a different role, but I really look up to you because the role that you have to build community engagement around the mental health is incredibly important, and also play a connector towards the most specialized services as well. My final point here is, I know that there's been the different technical working groups. I really appreciate that there is already in the discussion very concrete steps to make sure that the guidelines is operational and is practical, as well as the importance of developing SOPs and others. At the end of the day, I really see NDMA, SDMA playing a very critical role in operationalizing and coordinating the efforts. This is what I certainly see that you can play a very, very critical role, because it needs to be articulated in a way that I will argue before, during, and after the interventions and the programs can be informed by mental health and psychosocial well-being and are well articulated. And because I've worked a lot in emergency duty stations, I really am really aware of the very important role that the NDMA and SDMA can bring in operationalizing some of the systems and services that are going to be so critical to allow communities and children and families that are hit by a disaster to come back on their feet as quick as possible and recover a normalcy that will allow them to not only survive but also eventually move into a thriving lives. Thank you very much.
Thank you very much, Soleil, for that. Now can we have DG NDRF, Mr. Piyush Anand, please, for the valedictory address. Thank you.
Thank you, friends. Shri Rajendra Singh ji, member HOD NDMA, Ms. Horero, representing UNICEF, Shri Vatsa, member NDMA, and Shri Safi Rizvi, advisor mitigation NDMA. Dear friends, first of all, let me compliment NDMA for this excellent initiative, because we all know that the quantity and the quantum and the magnitude of disaster is increasing year after year all over the world, our country and the world. But I don't think anybody would have thought that this is an issue which needs to be discussed in detail about the mental health support for the victims after the disaster. Because one thing I can tell you from my experience as a police officer and as DG of NDRF, whenever there is a disaster, immediately a lot of agencies converge to the spot. There will be a lot of people, a lot of NGOs, a lot of government agencies, they are there to do some operations. But after a particular period of time, everybody withdraws, and finally the victims remain where they are. In fact, at that time, there's nobody to take care of them. So the first thing which the NDMA has done, which deserves a lot of credit, is that they have realized the importance of this issue, and they have, flagged it. They have organized such a wonderful conference and this discussion. Secondly, I can, based on my experience as a police officer and as chief of NDRF, that is something which is almost commonsensical. We all know that in most of the disasters, 95% of people who suffer are poor people. May it be flood, may it be landslide, may it be earthquake, may it be anything. And they are the people who have very little voice. So there are certain things which we can easily do. Number one, we should all realize that the most important actor in this game is the local administration. Normally within the Indian situation, that is called the district magistrate of a district or a deputy commissioner, depending on the state where you're working. So he has to be involved in all these situations, because there are various things which we may be discussing in various conferences, in various think tanks. But unless until he is there on the spot, as it was mentioned in the briefing session, that at times there are a lot of NGOs who are there on the spot, but then there is nobody to coordinate them. So we have to realize that there is one incident commander, and that is normally the district magistrate. So we have to actually keep the local administration in picture. The district magistrate and the local, we have a chief medical officer. He represents the state medical capacity in that particular district. So that person has to be on board. We have to actually educate him about the various issues. A good part or the bad part is that the districts in which the disasters happen keeps on changing. And the second thing is that the person who may train today, he may not be there tomorrow because there's a lot of attrition, a lot of transfers. But then that problem will persist. So somehow we have to ensure that the person who's there on the spot, he has to be made aware about these issues and what can be done. So as Mr. Safi Rizvi was mentioning that instead of a long SOP, they are trying to come out with a small SOP which the concerned officer can easily read when there's a disaster and take follow-up action based on that. There are certain things which normally one does if you are there in the field, that you should be, empathy and sympathy on part of all the persons who are involved, whether it is NDRF, SDRF, local police, home guards, fire service, health, ABCD, etc., etc. That empathy and sympathy has to be there. So this is something which is easier said. We can all say that in a Vigyan Bhavan conference, but as it was mentioned in the briefing notes earlier, that people are stressed. All the government functionaries who are there on the spot, they have been working long hours. They may not be getting proper rest, may not be getting proper food. So expecting sympathy or empathy for the victims is a difficult task, but then that is the bottom line, that is got to be done. Unless otherwise, this situation will arise. Second thing is that attention to the victim has to be there. It's not that once all the agencies withdraw, then we leave the person to his fate. At least we can ensure that his basic needs, assuming that 95% of the people who are the victims, they are poor people. So assuming that his basic needs, the state, the local administration should ensure that they are taken care of. His food, his water, his electricity, his medical needs. So at least he feels that he's being taken care of. But he should not feel कि यार मुझे तो बिल्कुल भूल ही गए हैं. जब हुआ था, जब उस समय कोई VIP आए थे, तो there were a lot of people taking care of me. अब तो I am running from pillar to post, nobody is there to take care of me. तो ये चीज़ें हम लोग यहाँ कॉन्फ्रेंस हॉल में बात कर रहे हैं, ठीक है, बिकॉज एक इशू को हम लोग एड्रेस कर रहे हैं. पर सबसे मुश्किल चीज़ ये है कि जो people on the spot, there are people on the spot, the district magistrate, the local medical officer, other agencies, police, home guards, fire service. How do we sensitize them? How do we ensure that this happens in case of a disaster? So that is a major challenge जो कि हम लोगों को देखना होता है. You would have all heard about the Wayanad landslide this year. You would also known that more than 200 body parts were recovered. So it's really unfortunate that we do not have any facility in our country where we can identify a dead body. We can take a fingerprint of a dead body and use that Aadhaar database to identify the dead body. So that is one thing which we can think about, that we can identify dead bodies based on the fingerprints. Because obviously whenever there is a disaster, 90% of the victims are local. So local people, you can do it by DNA fingerprinting. But that is one issue, that is the use of technology. Secondly, in case you have body parts or bodies which are dismembered, so then we should have the capacity of DNA matching of the remains so that at least the bodies are reunited with the victims and they face some closure. Because we have seen in many situations there are people who are looking as if next knock somebody will walk in and he'll be there near and dear one. So at least that is one thing, the technology can help us do that. The local administration, the role is very important. And again, basically the issue was flagged that there should be a module for this training in NDRF. That we will do. We will train our first responders about the first aid part of it. Then there was the issue of, this issue was flagged about YouTube videos. So that is again a great idea, and what I can suggest in that is that we have done in NDRF, we have created about 25 videos about various disaster situations, and we have translated them into 11 regional languages. So maybe whatever videos we are thinking of preparing or floating on the YouTube channels, we can do it in regional languages, because normally every state has a different language, and we have to ensure that this reaches the last mile. Everybody is able to look at the video, understand the video, and use it to the maximum. Then obviously we are talking of state-specific mental health SOPs. Again, they have to be state-specific, region-specific, because every state has different issues. They have separate culture. So a single SOP for the whole country may not work. So again, whenever we devise a SOP, it has to be a state-specific, culture-specific. Some states are huge. You may even have to think of having an SOP where you may have something, maybe 3 SOPs for a particular state, depending on the region. And the basic thing we always talk about is use of technology. We are talking of telemedicine, we are talking of the app, we are talking of having a video conference in that app. That is something which is easily doable within our country. We are the technological superpower. In that way, software is our forte. So that is one thing which we can actually use more easily. And because, as I mentioned earlier, 95% of people are poor people. And they may not be even having the basic technology. They may not be having access to maybe a smartphone. So there is one thing which we have to get the technology activated, and we also have to set up some service center which they can use to access this technology. In the end, I really thank NDMA for giving me this opportunity to be here, and I really compliment Shri Rajendra Singh ji and his team of officers for organizing this important session on this important topic. Thank you. Jai Hind.
Thank you very much, Mr. Piyush Anand. Can we have the closing remarks from Dr. Krishna as well, sir, please, member NDMA?
Thank you very much. My dear colleague, Mr. Rajendra Singh ji, Piyush Anand ji, Ms. Herrero, Safi ji, all the esteemed colleagues, participants, experts. When we started planning for this workshop, one of our worries was that the participation may not be that strong. You know, there may not be enough people to fill the hall. The turnout will be thin. But look at the turnout at the end of the workshop. You know, it's very, very impressive. We are very encouraged. And it just shows how people are interested in the subject, how people care for this area of disaster management. And we take so much of strength and courage from this turnout, the participation, the great discussion, animated discussion on the subject. It also shows a broader thing, that we are a caring and compassionate society, that we do care for the people, and this care and compassion is not one-off thing, that, you know, at a certain moment in grief, you know, we show that this care and compassion needs to be there over a longer period of time. We need to stand by each other. And we need to show support and solidarity. That is what matters at the end of it. You know, Gautam Buddha said, you know, dukh apariharya hai. No, sorrow is inescapable. You cannot escape. No one has escaped it. Everyone of us today in the hall has faced some kind of his loss, some kind of his sorrow. And how do we deal with it? We all find our own ways of dealing with it. You know, you go and ask, you know, people will give you different kinds of explanations, karma and God's will and this and that, and all that is fine. We understand that. But at the end of the day, we depend upon our inner resources to deal with that sorrow and loss. But, you know, what also matters is how the societal structures support you. You know, just one word, one line of assurance: we have your back, we have your support, we will extend you the full support. It goes a long, long way. We must understand this part, that sorrow, loss, and grief, they cast a long, long shadow. I still think of Latur earthquake, 3 o'clock at night, the earth shook. 8,000 people died within a matter of minutes, crushed, completely crushed, asphyxiated. They just died. Nothing could be done. No responder came till, it was morning. We sent army and everything, but 8,000 people died within a matter of minutes. That was still okay. 15,000 cattle, extension of the family. Cattle in agricultural family, they are extension of the family. They died. Think in the morning, 3 o'clock, 4 o'clock, what kind of screams would be there when the people would be crushed, when the cattle would be crushed? It would be rending the whole air. That trauma cannot be described. We recently, 1.5 years back, we had 30th anniversary of earthquake, Latur earthquake, and I was asking this question. Everyone said, trauma survives. It just goes on. People find it very difficult to deal with that trauma. And, many men who lost their wives, they got remarried, life moved on, women remained unmarried. Children were sent to orphanages. The life was turned upside down. And we provided all kinds of support, but where do we provide that kind of a human support? That is missing, and that we need to acknowledge that it's extremely, extremely important to provide that support to the people to stand on their feet, to reclaim their humanity. And this is what we discussed today and yesterday. How do we build that? How do we rebuild that? We have all the building blocks, everything we have. So, we have the counselors, we have the SOPs, we have all the SDMAs are actually very much involved with this. What we need is a good system, a regular system, through which we are able to reach out to the people and provide that kind of a support on a regular basis, on a dependable basis. We need to reach out to all the people. That's very, very important. And it cannot be done unless we invest in these services. And that is very, very important. NDMA, SDMAs need to come together. We have a huge mental support system. And we are so thankful to the Ministry of Health Services that they came and supported this. We realized that we have such an elaborate system of mental health existing in the country. And we definitely need to build on that. We do not need to reinvent that. And there is a clear recognition that we need to work together. We have mental health services at the district level, at the block level also. So now we definitely need to work with the Ministry of Health, Department of Health, to build this system, to invest in this system, to undertake more training program. So this is what we intend to do. We will build a national system. We will continuously be invested in this process. And we will have more differentiated service. It is not just about counseling. There are people have different needs. So those different needs need to be recognized. We need to deliver our services accordingly. And we also need to think of different groups, children, women, elderly, all of them have different needs. And all of them also, these things are very much also linked to the provision of all the other support. So this support, psychosocial support, mental health system, all this need to be, cannot be seen in isolation. This is part of a larger support system. And this is what we are committed to. Thanks for bringing out all the important issues. We have learned so much. We have been working on this issue, but we will be more systematic with our intervention. Thanks to the UNICEF for the wonderful support. You have been a great partner. And all the participants, I would like to extend my heartfelt thanks for your participation.
Thank you very much, Mr. Vatsa, for the most authentic exhortation for us to rise up to our humanity and for really elevating human resilience as community asset and the responsibility that all all of us as part of the community have to support individual experience of disasters. Now may I request, sorry? Now may I request Rizvi sir to please offer mementos to everyone. And with this, we close the 2 amazing days of intense learning. After this, we've got refreshments waiting for everyone.
Just one request to everybody, that we had a lot of effort put into this workshop by Dr. Ghanishta Suri. Please give her a good clap.
One in each corner. Thank you so much. Pleasure. A real pleasure. All the best. Stand up. All the best. And congratulations again. Well done.